I'm Dr Elizabeth Ailiff, one of the Royal Hospital for Women Antenatal Shared Care GP advisors, and I will be introducing the speakers. Today's event has been RACGP accredited for 3 hours of education activity. We will submit your CPD activity hours with RACGP on your behalf. 5 antenatal shared care points have also been allocated for this activity. For those joining online, you'll be able to submit questions via the Q&A. Please note that we will try and get to as many questions as possible. Firstly, just a little bit of housekeeping. The bathrooms are located on level 0 and level 1. The fire exits are located level 0. Please follow Royal Hospital for Women staff in the event of any emergency. We request that mobile phones be switched off or turned to silent mode. If you do need to take a call, please do so in the foyer so as not to disturb attendees. Please note, if you leave prior to the conclusion of the event, you will not be allocated your full RACGP CPD points. Afternoon tea will be from 2:30 till 3. For those of you here in person, please complete the evaluation by scanning the QR code in your packs. For those of you joining online, a link will pop up in your browser once the webinar finishes. A follow email with the link will be sent on Monday. I would like to introduce Professor Andrew Bissett, Royal Hospital for Women Medical Co-Director, who will welcome everyone on behalf of the Royal Hospital for Women, as well as acknowledging the traditional landowners. Thank you, Professor Bissett.
So I would like to start by acknowledging the traditional custodians and sovereign people of the lands across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us today. So welcome to you all to this RHW Obstetrics and Gynaecology update. The program speaks for itself. From my perspective, this is my 14th, I think it's my 14th occasion of doing this or participating in this. I do appreciate, and I would like to thank you for your attendance here. It expresses a clear commitment to quality care in maternity care and gynaecology. The landscape of antenatal maternity care is ever changing, as most things are in our world. I think the current challenges for us, a lot of them centre around the upcoming report from the birth trauma inquiry. We will be paying attention to that carefully, responding appropriately. On this program, there is also the very sad issue of domestic violence, and hence extremely relevant. Amongst other things, we are constantly, partly in a preemptive response to the trauma inquiry, where the theme of continuity of care comes up all the time in the hearings. We're trying to do more and more around that, so that all women receive a meaningful quantum of continuity of care, be that from midwives or general practitioners. It's the continuity issue that's important. Continuity of care, ideally carer, and continuity of messages, but you'll hear something about that. The issues around the pregnancy over 40, we do have the oldest population in pregnancy population, as in we have the highest number of women over 40 birthing here. Highly relevant. I would just say one final word. We do have a home birth service here, which is working very well. It's been going now for almost 6 years. And in that time, we've had an excellent mentorship program. It's worked very well with the hospital. The midwives, I'd have to credit them for, really upskilling themselves for all sorts of situations. There have been 2 occasions recently where the system has been stress tested, if I could say, and I would have to compliment the system for coping very well in quite difficult circumstances, because births don't always go well, as you know. So I'm very pleased with the home birth service. I just want you to know that. It's not for everyone, but it is an established part of our system of care. It is very appropriate for this area because the distances are not large. The women are very well resourced. Our staff are very keen. It's a very efficient and satisfying form of care. Anyway, I will leave you to the program. I wish you a beneficial occasion of learning and hand you over to Liz.
We are delighted to present a comprehensive programme today. In the interest of keeping to time, we request that you please reserve asking questions until the end of each presentation. Please also keep in mind that we have a lot of attendees here today, so please keep questions succinct and be mindful of others who wish to ask questions. I would now like to introduce our first speaker for this afternoon's session, Meg O'Neill, who's the Acting Midwifery Manager of Antenatal Outpatients and MAP Service at the Royal Hospital for Women, who will discuss the shared vision at Royal Hospital for Women. Please note this presentation with Meg, we will not be doing questions after her talk. She'll have a table out in the foyer in the interval. Please welcome Meg O'Neill.
Good afternoon. Thank you for joining us today for the biannual GP Shared Care Antenatal Conference in collaboration with the Royal Hospital for Women. My name's Meg O'Neill and I am the Acting Midwifery Unit Manager in the Antenatal Outpatient Department and for the MAPS model of care. And today I'm going to provide you with some updates on GP Shared Care and share the vision for the future of GP Shared Care at the Royal Hospital for Women. I would like to commence this presentation with an acknowledgement to country, acknowledging the traditional owners on the land in which we meet today. We pay respect to elders, past and present, and emerging. I extend that respect to any First Nations people who are with us today. Today, I'm going to provide an update on GP shared care and ways in which we can work collaboratively to share the same vision, which is women at the centre of our care always. I will touch on revision of supportive documents that will be coming in the next couple of weeks and go over a revised visit schedule, which is due to roll out with that document. I'll discuss referral processes, but that will also be addressed later in presentations. I'll also discuss support that we can offer GPs who are offering antenatal care. The GP shared care vision ensures that women remain central in the care that we provide. Continuity of care is a main focus for any model of care at the Royal Hospital for Women, especially GP shared care. Our vision focuses on the WHO principles of perinatal care, ensuring that women remain at the centre of our care. They have a choice and it's important that we're able to offer them continuity models. Ensuring women have a choice in their model of care is also important, and the care that we provide, it's important that we're promoting the normal reproductive processes at birth and childbirth are normal mostly, as we know, and it's important that we're able to triage women based on their risk factors into appropriate models. It's important that the care we provide is evidence-based and it's collaborative, and that a messaging that midwifery and medical staff are providing to women is consistent and the information specific to their needs. Information sharing is vital for this model for collaboration, and it's important that we update each other on any plans of care that may change or any variations from normal, and document appropriately on the antenatal card, which I'll go into later as well. Evidence-based care and education will support shared decision-making in this model, and shared decision-making will truly put women at the centre of our care. The core ethos of shared decision-making relies on the premise that self-determination is acceptable, and we can support women to achieve this by empowering them through education to make their own decisions. I'll do a brief overview of the models of care that are offered at the Royal Hospital for Women. So we have 3 main models of care, and each of those models have their subgroups as well. And the vision for all of these models is to ensure that women experience meaningful continuity, and it's a key priority to prevent women from having fragmented care. And I'll address this in later slides, strategies, how we can overcome this. So midwifery group practice, or MGP, is one of our models of care. MAPS, also known as maternity antenatal postnatal service, and of course GP shared care. Midwifery group practice is a midwifery-led continuity of care model. It's an all-risk model for all women where there's a named midwife who will provide antenatal, intrapartum and postnatal care. There is a named midwife who is on call for the woman, and a home birth, as Dr Bissett's mentioned before, is also an option on this model. There are also accessory models that are attached to MGP, which include MGP Malabar, which provides this group provides care for women and families who identify as First Nations people, and also MGP MFM, who provide care for women with complex needs during their pregnancy. And there's a clinical business rule on women who may be suitable on this model. So MAPS, or Maternity Antenatal Postnatal Service, is also a midwifery-led model at the Royal Hospital for Women. It is an all-risk model where there is a named midwife assigned to provide outpatient antenatal and postnatal care. And then when the woman presents to birthing unit, they will be triaged and seen by a core birth unit midwife. MAPS was previously a hybrid model operating with GP shared care. However, in December last year, this model transitioned over to full midwifery-led care, and this is in line with the wider vision for the organisation, ensuring that women have access to continuity of care models based on their risk factors, which is why this model was expanded. GP shared antenatal care, which is what brings us here today. So this is a model for low-risk women, and the care is provided collaboratively with the GP and a Royal Hospital for Women midwife. And the women have the option to have care provided by their known GP. And the benefits of that is there's going to be ongoing continuity with in the postnatal period and into childhood as well. So the vision for this model is to improve continuity for women. So women in this model will now have a named midwife. So you will start to see stickers on the antenatal cards, and that will outline who the midwife is caring for that woman. So generally from when the woman comes in for a booking in appointment at 14 weeks, whoever they book in with, the aim is that they will stay with that midwife to, again, avoid any fragmented care. So they will put a sticker on the woman's card, and that will assist the woman identifying who their named midwife is. It will assist the GPs knowing who the named midwife is. So if you do have any questions or you wanted to call and discuss that with a midwife, you're welcome to do that. And it also assists our admin staff as well when they're booking appointments to ensure continuity of care is protected. The schedule of visits for GP shared care model has been revised, and this was to further improve the continuity of care and based on relationship building. The review of the guidelines is to ensure both care providers have consistent messaging, feel supported to provide evidence-based care, and that communication remains open. The benefits are that women will be supported by their known GP, and they'll also have the opportunity to further build on those relationships. So I will go over the model of care revision. So this antenatal share guideline document is the current guideline which we are operating with. It is under review at the moment, but the advice is to continue using this document until the revision is finalised, and it will be circulated once it is complete. So the vision for this document is to have a structure that ensures that women will always remain at the centre of the care which we provide. The review will assist us to triage women into correct models of care early on in their pregnancy, and this again is going to prevent any fragmented care occurring. If women are able to be triaged into the correct model of care from early on in their pregnancy, that's going to prevent them from bouncing in and out of different models of care. So I think if we're able to give further clarity on women who may be suitable for GP shared care, ones who definitely wouldn't be, and when to refer back, or if we need to cease GP shared care at any point due to any medical issues that may come up in the pregnancy. There'll be a review of additional support services that will complement the model as well, and it's also important to cover education as the visit schedule has changed, and as I said before, it's important that we have consistent messaging that we're educating the woman with. It will be clearly outlined who will be providing what information and what resources we're using to provide that information. So the recommendation is to continue to use this guideline until it's reviewed. This is the protocol summary, which is attached to the guideline document as well. So the review from the guideline will filter into this protocol summary and it will be updated. But this is a brief overview of the recommended visit schedule between the GP and the Royal Hospital for Women midwife currently. So I will go over the new schedule with you shortly. But any feedback or suggestions are welcomed. If you do have any suggestions in the drafting of the new document, I can leave my contact details at the end of the presentation. In addition to the revision of the guideline, which aims to provide support, we have additional support available at the Royal Hospital for Women for GPs, and I encourage you to utilise these channels if you're new to the model or if you're experienced in providing GP shared care. As the policies, procedures, guidelines are constantly evolving here, things may change, and I always encourage you to call one of our midwives if you wanted to clarify anything. So you'd all know our wonderful GP shared care midwife Chantel, but we've had another fabulous addition this year to the team this year, Wei Ling. So we now have full-time midwifery support for GPs Monday to Friday from 8 till 4. 8 till 4:30. So you can contact them via mobile phone number, but I also encourage you to contact them via email, especially if you're working after hours or over the weekend. If it's a non-urgent inquiry, please send through an email and someone can get back to you on the next business day. So this is an example of the revised visit schedule, which has been carefully considered to ensure that continuity of care is the focus and that where the woman's really able to build a relationship with their care provider. So this is an example for a nulliparous woman, but the multiparous woman will vary slightly the visit schedule. So the main differences will be removing the range for recommended visits, which will improve clarity as to when the woman should present for a visit. It's standard for a woman here to be booked in by 14 weeks. So I do encourage early referrals, especially for women with complex needs, or if there's any indication that they may need to book in early. So an example would be someone with type 1 diabetes, any psychosocial considerations or complex medical needs. We can get them booked in early and then still it's better to be able to assess them to triage them into the right model of care. So there are the same amount of visits on the revised schedule. There is one additional GP visit. So that is at 32 weeks. And this is to complement the continuity with the GP. So the GP will lead care from the second trimester up until the woman is term. And then the Royal Hospital for Women will take over from term and help support the women into the fourth trimester. Some considerations also being given for women who are rhesus negative. So there's an anti-D clinic that has been set up to ensure that women are able to come in for the recommended gestations to receive their anti-D at 28 and 34 weeks. In line with the vision for care, I would like to bring emphasis to the document Connecting, Listening, Responding, a Blueprint for Action. And I feel the messaging in this document will be infiltrated into our vision for GP shared care for the future of maternity care. So the vision in this document promotes that women are to be given individualised information about their maternity care options, and that will form part of the review of the guideline, ensuring that our models of care are clearly outlined for you to take that back and provide education to women so they can make informed choices about what model of care may be suitable to them. The woman's choice has a large impact factor on the model of care they'll go into, but also we need to consider the woman's risk factors to ensure that she's in the safest model of care. It's important that care providers respect the woman's views, experiences and preferences, and health professionals support each woman to make informed choices. So I think that this is very important on the back of Dr Bissett's comments with a recent inquiry into birth trauma. It's important that we're really leaning into supporting women to make informed choices. So the key priority for this document for pregnancy care is that every woman should have a known GP and a known midwife. And that is the foundation already for our model for GP shared care. So we've already established that, which is wonderful. We need to ensure the channels of communication between health professionals remain uninterrupted and women are connected to care early in their pregnancy. So I encourage early referrals when indicated. The first, when pregnancy is diagnosed, I encourage you to send through an eReferral. We do receive a large number of referrals daily. So it is important that we're able to triage them. If there's anything that is urgent, please do call one of our midwives and we can look out for any specific referrals, especially if it's a late diagnosis of pregnancy or something that's urgent. Women are involved in shared decision making and they have the right to choose. So I think that that's really an important emphasis in this document, and especially with the ongoing parliamentary inquiry. Communication is also key on this model because the care is shared between two healthcare providers. It's important that we're updating each other regularly if there are any changes or variations in the care. So the antenatal record or the yellow card will be provided at the booking in visit from 14 weeks. So it's important that we're all keeping this document up to date as the best as we can. It forms part of our clinical communication, but it also involves the woman as that's the woman's handheld record, and it also involves her in the care as well. If there's any changes of or with plans of care, we will fax back any recommendations from the review. If a woman is sent in for a specialist review, on the GP shared care model, it is also provided by midwives the care, but there's also the option to see an obstetrician or one of our other specialists for an opinion. And if the woman does need to come off the GP shared care model, one of our specialists will provide you advice if we do need to cease the care. So I look forward to sharing this vision with you all. The vision will support us as healthcare providers to strengthen the service and participate in improving perinatal outcomes. Together we can improve women's experiences, and I think it's a privilege for us to work in partnership with women and their families. So if anyone would like to send through any suggestions for the review of the guideline document or protocol summary, I encourage you to send them to any of the emails listed on the screen, because we really value your input into the drafting of this document.
Yes, we can do that.
Yep. Yep.
Thank you. And the antenatal record, we don't need to fill that in when we're doing our first visits. Yellow card. Yeah.
So the yellow card, do you mean? So that will be given at 14 weeks when the woman books in, and then after, yeah, and then after that point, we both need to fill it in for every visit, yeah, and for any tests, yeah. Right. Thank you.
Thank you, Meg. I would now like to introduce the second speaker for this afternoon's session, Aaron Sebhag, Kristen Murray and Siddharth Ramani, who will discuss the electronic referrals. And again, they have a table outside in the foyer, so we please ask if you have any questions to ask them during the interval in the interest of timekeeping.
Thank you. My name's Aaron Sebhag. I'm the LHD project manager. Presenting with me will be Kristen Murray, who is our change and communications manager. And also joining us is Sid Ramari from eHealth, who's the eReferrals project manager. So in terms of what is an electronic referral, so electronic or Engage Outpatients is a program. It's a state-based solution sponsored by Ministry of Health and implemented by eHealth, and it's to be implemented across the state. And essentially, it's a solution to improve the referral experience of patients, referrers, and clinicians in outpatient services. What is it? Essentially, so Engage Outpatients is a program banner. It covers two solutions. And the first solution is called Electronic Referral Management System, which is ERMS. And this is a hospital-based solution for managing e-referrals. And next component is e-referrals, which are electronic forms, which is basically the replacement for your referral paper-based solution that can be sent directly to ERMS from your referral practice system and or My Health Link portal. So essentially, e-referral is an electronic document that can be sent securely, replacing all other methods such as faxing, posting, paper referrals, and referrers and patients will also receive notifications via their GP practice systems. This slide I'll get Kristen to cover off in terms of what the process is.
Thanks, everyone. This is a really high-level overview of the actual process, the referral process, which begins within your practices with your patients in your practice software, where you would submit and raise the e-forms through HealthLink or through the My HealthLink portal. Once all that information is being created and submitted, that is then sent secure message across into the eReferrals system, which is our hospital facility system, which is where we receive and manage the referral process through each of those phases. So we do have the received, screen, triage and post-triage admin phases, and these are where admin or triaging clinicians will access the referral electronically and make their notes and information is required relating to that referral. One of the key benefits in regards to this system is that as referrers, but also your patients, will receive notifications through each of these phases, advising them what's happening with this referral. So you are getting that real life information in regards to the referral that you have submitted. So leading into this slide, just obviously touching on a few more key benefits, not only for you and the referrers, you will have a better visibility of the services that we are providing, and electronic referrals is the preferred method. It is a faster processing time and triage, as all referrals are housed in the one platform. So therefore, we're managing all the referrals the same way. We're reducing that lost and misplaced referrals, which has ultimately happened or can happen with those paper-based referrals with your fax or email to the wrong departments. And ultimately, it is definitely a better and faster intervention and a better health outcome for your patients ultimately at the end of this. We've had some really positive feedback for those GPs that are currently using this system, and some of you may have been, as Sydney LHD have been accepting electronic referrals for the last 2 years. And you may have been aware of this as HealthLink. You're using driver's license assessments and aged care referrals in the same methodology. So it's extending that functionality of that HealthLink portal and raising those electronic referrals into the service. So currently Prince of Wales is live. We were the pilot site for the district, and we are now live with 24 services. And this is the preferred method that we would like to encourage for these services that we do have. What's happening next? So a business case obviously has been approved, and we are looking to further extend, and we're really encouraging you as referrers to use this functionality. We're extending into Sutherland Hospital at the end of this month on the 29th of May into their centralised outpatients department. We are then coming back into the Royal Hospital for Women and those 5 main services. So Royal will be predominantly working towards moving away those faxed referrals. So really encouraging you to submit your referrals electronically in this method for these services. We are then also extending into the start of July, extending the Prince of Wales services as well. So respiratory, diabetes and physio will extend. So we'll move on into 27 services. So I'm going to hand you over to Sid from HealthLink Healthcare, and he's going to do a discussion about the HealthLink.
Thank you for that. Sorry to keep you all waiting. Just had to fire up the website for a quick demonstration
of the eReferral forms. So what you see on the screen is the HealthLink SmartForms platform there. It's a demo website, so it looks a bit busier than the usual presentation. So the way you navigate it to it will be from your practice management software. You'll see a HealthLink icon like this. You click that, you launch it, and you land on a web page like this. And once you're in the web page for the Southeastern Sydney link, you'll see New South Wales Health Outpatient Referral Southeastern Sydney. You click into that. Was not meant to do this.
It worked properly.
Okay. Yeah, let me see if another one works. Okay, technical difficulties. Yeah, I'll just go to the slides. Wasn't meant to be. Apologies. So essentially, I don't have a visual to talk through, but the HealthLink SmartForm platform has, it's integrated with a practice management software. You can pre-populate all the information from there. So you can, sorry. Yeah, so the way you access it is from your practice management software. There's an icon that you can use to launch the HealthLink SmartForms platform, and it's tightly integrated into Medical Director, Best Practice, Genie, SheXC, ZMed, all of those practice management software. And once you're in, you're able to pre-populate a lot of the information. You can pre-populate all your attachments and reports. You can also attach it from your PC, and then there's just a few mandatory fields to complete. So we estimate about 3 to 8 minutes, depending on the complexity of the referral, to furnish all the information. And what we've done in the development of those forms is we've had statewide panels, both on the clinicians from the LHD and also a statewide panel from the GPs across the state to give us the usability feedback. Sorry, the clinicians gave us the feedback on what's required for each of the specialty areas, and the GPs gave us feedback on what's required. How does it fit? Are they able to submit all those reports that's being asked of them? And that's the way we develop the form, so that it's nice and easy for you to submit all the information without. And we also don't hold the referral back. So if there are missing attachments, or if you don't have it yet, or if you think it's not relevant for that patient referral, we don't hold the referral back. You can click through the, reason of why you don't have that information, provide that information, and the referral goes through. And the other key benefit, Kristen probably highlighted, was the two-way communication. So once the referral is sent, as soon as the referral is sent, and there's a slide for that one, you get the notification upon receipt as soon as it's triggered and sent to the eReferrals platform, and you get a notification also on when it's on hold, so the LHD can go, oh, we need extra information to be able to triage this, so they can put the referral on hold and then send that information back through to your practice management software. It sits all in the patient context against your patient as to what is missing. And I can show you an example of what that looks like. So you get a notification pretty much at every step of the way. If the referral's redirected, the patient also gets a notification. If it's not accepted as well, patient and GP both get notification. And then if there's a triage outcome, accepted or not accepted, or if it's cancelled for whatever reason, if the patient didn't turn up, or it was cancelled by yourself, or they didn't attend. So at all of those different stages, you get notifications so that you're abreast of the whole referral journey throughout the referral cycle. So this is what some of those notifications look like. It'll be pretty much like an email saying where it's coming from and the different stages, and
and when it's triaged and cancelled as well. And then here's sort of an example of how it looks in your practice management software. It sits within that patient context here. You can see Optimus Prime is the patient, and then the notification against that asking for further pathology results. So it makes it all in the one place so that you can see it all in your practice management software. It stores a copy of the referral within your practice management software, delivers it securely into the RMS system, and you have all these two-way communications that facilitate, ease of communication in that sense. Any questions? Great question. So you'll get notifications through the system into your practice management software once antenatal's live. I think 12th of June.
Yes. So the 12th of June, we're going live into the Royal Women's, and antenatal is one of the services that we are going live. So if there is any extra information, like Sid's just mentioned, we've got that two-way communication. We'll be sending that communication through your practice software. That will be the preferred way that they will communicate with you if there's information that they need for that referral to advance to the next phase.
About each antenatal visit at the hospital, will that be communicated to us by email rather than this?
That probably will be the plan long term, to remove the faxes altogether. We receive a substantial amount of faxes each day, so I think if we were able to move to the digital, that is part of the plan. It isn't happening with the rollout. It won't be happening with the rollout of these e-referrals for this stage, but hopefully by the end of the year, yeah. But if you wanted to start utilising email, then that's encouraged as well.
Yep.
It's inadequately sent, and you have to resend. You have to do the whole thing over again, or how do you resend it?
So there's an update feature coming through. There's an update feature coming through very shortly. Actually, that'll go live with the Royal Women's thing. So so when you get the notification that, let's say, they need additional pathology, you can go into that update feature as opposed to starting a new referral. And in that update feature, you're able to retrieve open referrals for that particular patient, and you can select which referral, and then say, it's a very simple screen, 3 radio buttons, and then you can say, yeah, this is what I'm sending the update for. Put a small narrative and attach the thing and send it off, and it'll go into the RMS system. So again, rounding out the two-way communication.
Okay. Thank you, everybody. If you have any further questions, if we have any further questions, please feel free to reach out. You're going to get these slide packs, I believe, and does have all of our contacts on there. So if you do have any further questions, but thank you for your time today.
Thank you.
Thank you.
They'll be around at the interval as well if you do have further questions. Moving on to our next speaker, Wendy Hudson, who's the Acting Nursing Clinical Co-Director in Women's Health and Gynaecological Services at Royal Hospital for Women. She's going to be giving us a short presentation on abortions, otherwise known as termination of pregnancy.
Welcome, everybody. So I won't do another acknowledgement because we've had 2 this morning. So the abortions, termination of pregnancy service at the Royal Hospital for Women is under development at the moment. This is in response to the Abortion Law Reform Act of 2019, when it was requested that public hospitals provide a service for women having termination of pregnancy. Achieving equity for access to abortion for all women is critical, as you're all aware, and currently there is a lack of equitable access to abortions in New South Wales with little public health hospital systems. The Royal is reviewing our service and developing a clinical pathway to improve this access for terminations of pregnancy by developing a clinic that will be providing medical and surgical terminations. This is for the woman's choice, and important, the choice should not only be limited to women in higher socioeconomic brackets, but also living in urban areas, regional areas as well. RANSCOG supports the woman's choice of her method of termination, which is most acceptable to them without coercion, informed by their values and their preferences. Women will be referred to our service through eReferral when this comes online as well. One of the referral processes will be in our gynaecology department, and that referral will come through to them. We currently receive referrals for terminations of pregnancies through GPs, social work, through the private practices, clinics as well, Murray Stopes, family planning. We receive a number from Kirkton Road, also through our EPAS service and through private obstetricians and private ultrasound practices. So it's a large volume of referrals that can come into the hospital for these women, and then how we triage those referrals. So women are referred for clinical review dependent on gestational and the issues associated with their pregnancy or what's going on in their life at the time. The Royal is often seen as the last point of referral, and we receive requests from out of area and occasionally interstate. The PHN pathway advises women to self-refer to private terminations services, as there are no top services currently available in public hospitals. So I think having worked on this project and speaking to other districts, a number of services are out there. It's not advertised for GPs and for women to actually know that the services are available, but public hospitals are providing a service, but not an advertised service as such. So the Royal does not provide an early routine abortion service. So for women who are requesting an early abortion, that is generally provided through general practice, through your general practice, and also through private clinics in the community. The criteria for referral coming to the Royal to facilitate the care for these women is around not all women being referred here for an abortion, termination of pregnancy, but for women with complex medical or social needs, people who are vulnerable and are all disadvantaged, young adolescents, people with a health card, and women who are within our own catchment areas. So we won't be taking women from other LHDs. They will be referred back to their LHDs. So we're just trying to support being able to provide a service that is equitable for these women. The specific type of termination provided, whether it be medical or surgical, will be determined by an assessment on the individual's clinical needs at the time when she sees the consultant. Again, just to reiterate, we do not provide an early routine abortion service. Referrals will be sent to the gynae outpatients department for the termination of pregnancy clinic. So currently it's the fax referrals process, but eReferrals coming from July will be our referral process. The termination of pregnancy referrals will be triaged by the coordinator of the clinic, and the referral must meet the criteria. So if health professionals are welcome to contact the clinic, and this phone number that is attached here will be available for the service, and we will inform you hopefully in the not too distant future that this is actually up and running and available with a coordinator who will be able to return calls once the phone calls have been triaged. The service itself will only be a 3-day a week, have the coordinator available 3 days a week, so she will triage the calls and get back to you as soon as possible. For low-risk women who are not requesting funding due to financial hardship, the referral will be returned back to you because we won't be accepting all referrals for abortions, termination of pregnancy. It's only for the specific criteria of women that will be coming to the Royal. To prevent delays, including the following information, what we require at the hospital is that the woman has had a pelvic ultrasound for dating scan, pathology, including a beta-HCG, full blood count, rubella, Hep B and C, HIV and syphilis, and then also STI screening for chlamydia and gonorrhea. and noting that anti-D prophylaxis for Rh negative patients is no longer required for early abortion services. So reporting terminations of pregnancy, we've collated some data back from July last year to this year and around the increase in women that are being referred and being seen at the Royal. And as you can see from this data, most of our women present at that middle gestation 9 to 16 weeks, but or 15.6 weeks. And from 16 weeks onward, all of our women can only have medical terminations. We don't do surgical terminations greater than 16 weeks at the hospital. And most of these women who have been greater than 16 weeks and from some even greater than 22 weeks often have fetal abnormalities. The significant number has been for fetal abnormality, but there's also those women that are requesting termination of pregnancy for their life choices and what's happening in their life. So from 22 weeks, there needs to be 2 consultant obstetricians who agree to do the termination. So there's lots of counselling. As you know, you will provide counselling for women as well. And the services that are available for that. So the references that we've used are our local policies, but also the Abortion Law Reform Act and the summary, the framework of termination of pregnancies from New South Wales Health, the RANSCOG guidelines, our local business rules themselves, and our EPAS policy as well. And that's me. Okay, so there will be more information coming around that for you.
Thank you for that update, Wendy. I'll now introduce our next speaker, Iqra Khan, Clinical Midwifery Consultant at Royal Hospital for Women. He's going to be giving us a short update on the hyperemesis gravidarum update.
Hi, everyone. I might move this down a little bit. There we go. So as it was mentioned earlier, my name's Iqra. I'm the CMC for the Hyperemesis Gravidarum Initiative in South East. So I'll be talking to you a little about the update of what's been happening across the different sites. So I thought we'd start with some definitions. So it's mentioned as NVP, which is nausea and vomiting in pregnancy, very common and affects around 69% of all pregnancies. Nausea and vomiting in pregnancy is defined as dry retching commencing in the early pregnancy without another cause and is not classified as hyperemesis gravidarum. HG starts in early pregnancy and is characterized by severe nausea and vomiting, an inability to eat and drink normally, and thoroughly limits daily activities. Things such as dehydration, ketonuria, and weight loss should be considered, but are not necessary for a diagnosis. As I mentioned earlier, nausea and vomiting is very common in pregnancies and affects 69% of all women in New South Wales. HG actually affects around 1.1 to 3% of these women. We think this number is highly likely to be underreported, as we're finding since we started the initiative and work on improving care pathways, these numbers have increased dramatically. So HG is the main cause of hospitalisation for women in the first half of pregnancy. And some significant impacts include dehydration, ketotic state, weight loss, vitamin and mineral imbalance, fatigue, psychosocial issues such as depression and trauma, anxiety. We've had a lot of women reporting negative impacts on family units and loss of earnings. There is a small increased risk of premature labour and SGA babies. There's very small amounts of research out there at the moment. And also it can have a significant impact on future family planning, which is one of the reasons I think it's a very important issue. So many women who have experienced significant HG in pregnancies choose not to have any more children or may actually opt to have a termination of pregnancy for that pregnancy itself. So this is why it's quite an important issue in early pregnancy and women's health. So a little bit more about the HG initiative. The HG initiative is a 4-year long project that's been led by the Ministry of Health. And part of the initiative has involved releasing a new guideline, updating the PHN SESLHD guidelines. We have a draft that's been rewritten in the last couple of months, so that's just undergoing some further review. We're integrating the puke score into routine care, slight changes to the medication management, some enhancements in the mother safe services, and new pathways for women in each of the hospital sites across the district. We also have the availability of something called compacts, which I'll be talking about in a final slide. So that's non-clinical support for these patients as well. So just to run through quickly the puke score, which I'm sure most people here have heard of. The pregnancy unique quantification of emesis score is 3 questions that we advise as a baseline for diagnosing women with hyperemesis or nausea and vomiting. The total score is out of 15, and as a general rule, we recommend that these questions are asked to women at every visit before 16 weeks, and a lot of those visits are happening with you guys at the GP. We do recommend that you can use this score past 16 weeks. However, that's just completely on your clinical judgment. Sometimes when women are scoring slightly lower, sort of between the 7 and the 12 mark, it's not necessarily recommended they need in-hospital treatment. However, we've realised that this is very much dependent on the woman's own condition and how she appears to you. So later on, we'll talk about the medications and the things that we do for certain puke scores, but there's a lot of flexibility around it, and we will just take each woman on her own case. So the main ways to treat NVP and HG is obviously to reduce the nausea and the vomiting, to manage the gastric dysmotility, to maintain adequate hydration, which we find has worked the best. Lots of psychosocial support. It's a big part of the whole care package, and try and prevent the side effects and adverse pregnancy and fetal outcomes. So this table has been transferred straight from the state guideline, which was released in 2022. So the state guideline summarises different types of medications and dosages as per the puke score. As I mentioned previously, there is a lot of flexibility around this, and it really depends on how your patients are tolerating the medications they may have been prescribed. The main things to remember is we start off with the antiemetics. Please add laxatives if the lady is on any antiemetics. Particularly ondansetron is very constipating. 1 dose will constipate a woman for 8 hours, and it just adds to the symptoms that she's feeling, and it can make them feel much worse. We also recommend starting some acid suppression, and depending on how they're doing, consider some regular IV therapy. One of the things to also note is that the IV therapy is much more useful if it's regular and repeated. So sort of sending them in for 1 bag of fluids in a week is unlikely to have a positive impact. And we're actually encouraging women to be attending really regularly, up to 3 times a week for IV therapies. So just a quick summary, because that table is quite busy, is that with mild, which is basically your early puke scores, ginger and pyridoxine, which is very easily available over the counter. The only note to remember is with the ginger, we don't advise that it's just, add some extra in the cooking. We do recommend supplements from the store. There's a certain dosage that we would advise for that. Moderate to severe, the first line is the most commonly used ones in SESLHD, and it's particularly at the Royal, are doxylamine, metoclopramide, cyclizine, and promethazine. As you may be aware, a lot of these are antihistamines. They have sedative effects. We recommend only 1 antihistamine at a time. Generally, if they're going to work, particularly, for example, metoclopramide, we will know they are working within 2 to 3 days. If it gets to 5, 6, 7 days and the patients are still not resolved and the puke scores are not lowering, the patient's still not feeling much better, it's really important to consider that it just might not be working. And what I've experienced is that a lot of mixing and matching sometimes works. So normally sort of a sedative one in the evening and then something else in the morning is what the patients generally need to keep them going. The second line for moderate HG is ondansetron, and the main reason that it's been classified as the second line is because of the potential of side effects. This is generally after we have tried a first-line medication. It is superior to the first-line options, and I'll talk about the potential side effects in the next slide. The wafer, which is which most people seem to think that would be easier for the nausea and vomiting, is actually very, very bitter. And so we actually recommend that the women try tablets because they're much more tolerable. Mentioned earlier, it has a very high risk of constipation, and unfortunately, it is quite expensive as well. It's just something to let your women know that they might be expected to be taking 3 doses in a week, 3 doses in a day, and therefore the cost can add up quite a significant amount. So just talking a little bit more about ondansetron, as it's been a bit controversial in the past. The initiative has been working really closely with obstetricians, obs med physicians, and pharmacists. We have discussed that there's no statistical significance associated for the overall risk of congenital malformations. So there is a 0 to 1 additional risk of having a baby with a VSD for every 330 births, but the background risk in Australia is actually 1 in 240. And there is a 0 to 1 additional risk of having a baby with a cleft palate oral cleft per 3,700 births. Background risk in Australia is 1 in 800. So the risk does exist, and we have to recognise this when we are counselling our women and our patients. But we should also be reassuring them the risk is very, very small, and it's very dependent on how they're feeling. So at the time, the priority would be to resolve the HG and the NVP. I've just popped this slide on. This is all about steroids as a third line and sort of like your final treatment when nothing else seems to be working. Prednisolone does cross the placenta, but the fetal uptake is very limited. There's very little data on the use of steroids during the first trimester, but we think there's no overall increase in congenital malformations. Steroids should only be really considered as a third line final treatment dose. And it should be likely that the woman will have had specialist care either with an obstetrician or an obs med physician at this stage. As a general, with our care pathways the way they are at the Royal, at St George and Sutherland, we would then be referring on to the right medical teams to start these kind of medications. Many people here would have heard of MotherSafe, which is actually a statewide service, but it is based here in the Royal Hospital for Women. So MotherSafe continues to be the gold standard for medication safety. And this is during preconception, pregnancy, and breastfeeding. And with the HG initiative, they have actually grown and enhanced their service to include a much more comprehensive assessment of women who may phone up with NVP and HG. So they talk about the puke score themselves. They do a history of symptoms. They discuss other medical conditions and medications the women may be on. And then they can sort of make a plan with a follow-up as well. So they've also, because they're in a statewide service, they are mentioned all over the state, and they've done a mapping tool. So if you're not sure of a woman's local services, MotherSafe has been able to track that across the state. So they'll be able to let you know what's available for her wherever she may be, whether that's in Sydney or outside. The counsellors are also available on extended hours, but these MotherSafe counsellors are also there to talk to clinicians and community staff as well. So if you're not quite sure about a script or you're not quite sure about a plan for a woman's medication during HG and MVP, please give them a call. They'll be more than willing to have a chit chat about it. The HG NVP MotherSafe team has also established a system where we can actually access an obstetrician appointment by telehealth. This is generally reserved for the women who live in rural areas who may struggle to get out to local GPs. But it's just good information to have if that does come across. It's also particularly useful for women who may have other reasons, social issues, that may be stopping them from being able to access the local GP and pick up the scripts. So that's been working really well over the last few months as well. This slide is just a bit about what we're doing here at the Royal Hospital for Women in itself. Women should be referred to our pregnancy day stay unit for treatment and review. The pregnancy day stay unit is a Monday to Friday, 8:30 till 4:30 system. So unfortunately, out of hours, it's still ED. There's a number up there which ideally we should just call and get the referral done. Depending on the time of day and the workload in pregnancy day stay, the midwives may be able to facilitate care on that very same day. If possible, please provide a written referral to explain what you've seen of the woman yourself. So a puke score would be great. And if you have started any medications in the community and the GP surgery, just to let the team know. When the lady arrives to pregnancy day stay, they will have an obstetric review and we'll just probably titrate those medications a bit more. It tends to be a couple of different types of tablets with complicated names, and a lot of the women are not able to just sort of let us know verbally. So it's always good to have it written. We are also encouraging early bookings with the maternity services. So generally, if a woman has attended pregnancy day stay for fluids or has gone to ED, please consider advising the woman to book sooner into the Royal Hospital for Women self-referral pathway on the website. And if you can note in the current medical conditions that she's had treatment for HG or NVP, we will try and see these women much sooner than normal. The early booking also means they have access to psychosocial support from inside the hospital as well. Without the maternity booking, we can't access all these services. We now are also offering hospital in the home care for women with NVP and HG, and this is in a partnership with the Prince of Wales team, which is already an established HIF team. We can give IV fluids and medications over the 7-day period in the week. Usually it's alternate days. And they usually give a phone call every single day to the woman just to see how she's doing. The referrals at the moment are coming from PDSU. So if you think there's women that will need regular IV fluids, please send them into PDSU. We'll ideally refer them on to HIF. And we're planning to have the ED referrals coming through as well. So if the woman does need treatment on a Sunday and she goes on a Friday night, someone should be able to visit her at home on the Sunday. I've just done a quick summary about what's happening at St George and Sutherland. So St George, the women need to be referred to the Early Pregnancy Assessment Service for a review. And again, out of hours, it is ED. The women can also self-refer to this service, but they must present between 7 and 8 a.m. Monday to Friday. The St George Hospital has also established a hyperemesis and HIF service and will accept referrals from EPAS, ED or GPs. So if you are thinking that you would like to do a direct referral, you just need to contact EPAS and let them know the details and they'll be able to get that done for you. At Sutherland, the women will be seen on the antenatal assessment unit / the birth unit, which is actually a 24-hour area. Ideally, please, we would expect a phone call with at least the puke score and what's been going on with the lady and sort of when she would like to come in as well. So in general, a hyperemesis appointment can take up to 180 minutes. So it's a lot to do with working out when the most appropriate time is to start that appointment. Women less than 20 weeks are also able to be seen in this area, despite being part of the birth unit. And that's just for hyperemesis and nausea and vomiting women only. There is also a HIF service available. The Sutherland HIF has just gone live around November last year, so it's quite new. And hyperemesis and MVP is part of the demographic of women they will be willing to see. We are just going to await a go live once we've confirmed the medical governance. But we have got a midwife named as the project lead there. So as soon as that's available, I will probably try and reach out to the GPs and let them know via your newsletters and things. So, of course, this is all to do with a lot of community care and outpatient care, but there are some admission triggers which are pretty much the same across the board. So several severe electrolyte disturbance, renal impairment, a significant comorbidity or a person requiring essential medications, significant malnutrition or significant weight loss, and potentially any other conditions that you may think warrant inpatient management should be referred into the hospital for that. It's usually a case-by-case conversation, and often the referral pathways for outpatients will be happy to discuss the details for each woman as they come. So if you're not sure, please contact the PDSU, the AAU, or the EPAS system, and they will let you know as well. And then this is one of my final slides. So this is to do with compacts. Some people may have heard of this before. It's historically been used for quite like geriatric patients or wound infections in the community. Compacts is non-clinical community support. They come in 6-week packages whereby we can assist women at home when they are feeling particularly unwell. And some of the most commonly used support packages for hyperemesis have been the domestic assistance. So someone coming to the home and helping them with the cleaning, transport to and from hospitals, or providing even taxi vouchers. Meal prep or food shops as well. They generally are the ones that we see. They also available for social support. So if the woman doesn't warrant a full psychosocial assessment, it might be useful for her to have the contact details for the compacts clinicians. All HG referrals are triaged to ensure they fit the eligibility, and generally the best and most efficient way to get the compacts referral is either to be able to do them yourselves if you have access to the portal, and if not, all social workers in every hospital do. So you can just contact whichever hospital the lady is linked to and get the referral sorted that way. And I think that's pretty much it. This is my email address. So if you have any questions or anything that I can help with, let me know. And the numbers, I think hopefully you'll get a copy of the slides. So the numbers for the different entry points into the hospital will be available for you too. Thank you.
Thank you for that, Iqra. I'll now introduce our next speaker, Dr Rahul Sen, who will be giving a presentation, Pregnancy Over 40. Dr Rahul Sen is a specialist obstetrician and gynaecologist based at the Prince of Wales Private Hospital and the Royal Hospital for Women. He has consulting rooms in Edgecliff and McGorry Street. Please welcome Dr Rahul Sen.
Thank you. Hi, everybody. I'd like to thank the organisers for inviting me to speak. I'm going to talk about pregnancy after 40, which is an increasing part of my practice. So I trained at this hospital and my practice is mainly in this area. My main rooms are in Edgecliff, also in McGorry Street. And so I'm just going to talk a little about pregnancy for women over 40 and some sort of fairly simple strategies for mitigating some of the risks of women over 35, over 40 and over 45, which I'm seeing increasingly in my practice. So age matters. At age 4, success is not peeing your pants. At 21, for some reason they haven't. So at age 4, success is not peeing your pants. At 12, it's having friends. At 16, it's having a driver's license. 20, going all the way. At 35, success is having money. At 50, it's having money. You can see a trend here. 60, it's going all the way. 70, it's having a driver's license. 75, having friends. And 80 is not peeing your pants. So age matters. But age is also a sensitive issue. Just ask this guy. So age is a problem, and it's a problem in obstetrics, but it's one that we have to address. So risk is basically a continuum throughout pregnancy in terms of age. Increases after 30, continues to increase after 35, and significantly increases after 40, and goes on after 45. And I think, so I'm not sure why this, apologise for the sound effects, they're not deliberate. The age issue is analogous to the gestational age issue. So as the risks of age go up, the age at gestation goes up. So I think gestation is really important in pregnancy, particularly when we're talking about planning optimal timing of birth. We also know that the proportion of older women getting pregnant in New South Wales is increasing. It is Australia-wide, but in New South Wales, it is disproportionate to the rest of the country. And in this part of, so in Sydney and in the eastern suburbs in particular, having worked in different parts of Sydney and different parts of Australia, these figures are not uniform. But this is an area that's particularly pertinent to this region. We're seeing a slow, so in a 10-year interval between 2011, the numbers of women over 40, over 45, over 35, over 40, and now over 45, which used to be almost unheard of, is now, becoming uncommon, but definitely numbers. And we can see that the associated problems, fertility problems, and pregnancy-related problems, starting with miscarriage. And if you just look at age-related trends, when you're sort of 20 and you're young and a bit silly, your chance of getting pregnant is extremely high. We know that 50% of pregnancies in Australia are unplanned, and also the outcomes in pregnancy are good at that age. Abortion rates, spontaneous abortion or miscarriage rates are low, and I'll come to the other risks. They're all low, and the fertility problems start to increase sort of after 30. Miscarriage rates go up after 30. And then we know that just looking at the fertility problem, so fertility falls steadily after the age of 35, and Kirsty Allsop, who used to present Location, talked about pregnancy falling off a cliff, for which she was sort of widely criticised, but she's not completely wrong. It does drop dramatically after 40, and it really does fall off a cliff after about 43. And by 43, it doesn't matter what you do. It doesn't matter whether you try IVF or whatever. I mean, maybe IUI might help, but really once you're 43, you're in trouble if you haven't conceived, although some women do spontaneously, and that's great. But planning it makes life difficult. I do sometimes get asked, what's the value? Is there any value in doing AMH at this age? No, not really. So AMH, when it first came out, was a fantastic test and thought to be the be-all and end-all, and doesn't change, but it can change. And of itself, it's not that helpful. AMH, together with antral follicle count, is reasonably helpful in predicting ovarian reserve, which in turn is useful for women planning to delay fertility. So if you've got a woman who's 30 and perhaps not in a relationship, or in a relationship but not ready to have children yet, who wants to ask the question, is AMH good? Yes, in that setting, AMH and antral follicle count is great, because if those suggest reduced ovarian reserve, then that woman could do egg freezing to preserve fertility, if not in a relationship, or obviously IVF and embryo freezing if she is. And we know that miscarriage rates increase significantly, up to quite an astonishing 50% by around age 40, mid-40s. And many women are surprised by how common miscarriage is, and for women who've never had it on their radar, they're totally bewildered by something that they'd never seen coming, and find it terrifying. And the most common causes are trisomy 21 and monosomy X, or Turner syndrome. When I'm doing curettes for women who've had miscarriage, I do tend to do microarray, because I do find that about 50% of the time, we get a chromosome diagnosis, which helps confirm exactly what the underlying reason was. About 50% of the time, we get a result, which is then helpful. So sort of busy-ish slide, but if you look at in the different columns, the things associated with age 40, you can see the combined risk of aneuploidy. Most of this is trisomy 21, but the combined risk of aneuploidy is about 1 in 39, compared with roughly 1 in 1,000 at age 30. The risk of ectopic pregnancy goes from 1 to 2% to 5%. The risk of spontaneous miscarriage, as I've mentioned before, is around 50%. And even after heartbeat's been heard, the miscarriage rate's still around 30%. So very, very high rates of miscarriage and early pregnancy problems. So the other risks that we know, and all the data looking at advanced maternal age show these, the figures vary slightly, but they all show that similar sort of things. Increased risk of twin pregnancy. I'm sorry about that beep. Placenta previa, gestational diabetes, preeclampsia or gestational hypertension. So we know approximately 10% of pregnancies will be complicated by some sort of hypertensive problem. Preeclampsia rates about 2 to 3%. And now, of course, we have the option of mitigating risks of preeclampsia, especially early onset preeclampsia, by commencing low-dose aspirin. I'm going to come back to that. Preterm birth rates go up significantly over 40. Small for gestational age or large for gestational age, risks increase significantly. And of those, of course, small for gestational age is the worry. Large for gestational age, not a big problem. Those are robust babies. Yes, they might get stuck in labour and need a Caesar they hadn't planned, but that's not such a big issue. Small for gestational age, a big concern because they're overrepresented in the stillbirth group. And I'm going to come back to stillbirth because I think that's super important in this age group. Late stillbirth, as I've mentioned. So after stillbirth after 38 weeks becomes increased risk in women in this group. Women are more likely to have cesarean section, partly planned, but also this represents unplanned increase in cesarean section rate. They also have greater chance of very long labours, awkward positions in labour, breech presentations, hemorrhage after birth. Placental abruption was a rare event, but more common in older women. And the different studies have shown slightly different findings, but overall they're very similar. And a slightly busy graph, but basically what it's showing is that most pregnancy risks are fairly low between about 25 to 30, and after 35 start to increase. So if you're planning pregnancy, then age around 30 is an ideal time, and after that risks increase. Now, we do have some strategies. So one of the issues that I think is very important is dating scan, and I know that New South Wales Health doesn't routinely recommend dating scans, which I fundamentally disagree with for a couple of reasons. One is you want to know that there is a single pregnancy there. You want to know that there's a heartbeat there. And if you don't do a scan till 12 weeks, it may be that the woman who's had normal early pregnancy symptoms but not an ongoing pregnancy doesn't get that information until she thinks she's almost in the second trimester. And yes, it absolutely doesn't change the outcome, but it prevents her from thinking that there's an ongoing pregnancy for an extra 4, 6, 8 weeks. And so the second thing is that you can provide the opportunity to do a planned procedure. So manage the miscarriage. May want to wait for spontaneous resolution, but may want to have an ERPC procedure. May want to have genetic testing performed. So one of the increased risks is aneuploidy, especially trisomy 21. We're very fortunate to have quite reliable, non-invasive testing, and you're obviously very familiar with the various different platforms. There's not that much difference between them. So the basic one would be Harmony or Generation, which looks for the 5 most common chromosomes, so 13, 18, 21, X and Y. The parents can find out the sex if they want to know, but also that could be not disclosed if they don't want to know. I think it is important to do all 5 because you can still get sex chromosome aneuploidy. Of course, NIPT is not covered by Medicare, so parents have to choose to pay for it, and it's $450, $500 depending which one you do. I tend to do the expanded NIPT. So I do Percept or Generation 46. So look at all three sets of all 23 pairs of chromosomes. Just it casts the net a little bit wider, although even that's not without its own issues. It's important to remember that the NIPT gives you only information about the chromosomes, and separate from that, I do have a discussion about carrier screening. You're all familiar that since November of last year, Medicare funds triple carrier screen as a sequential test. So the woman does the test either pre-pregnancy if pregnancy planning or early pregnancy if already pregnant. And if she's negative, we don't do any further testing. If she's positive, we screen the partner. And if they're both positive, if they're both carriers for any of the triple screens, so cystic fibrosis, spinal muscular atrophy, Fragile X, then we would usually offer an amniocentesis to check whether baby was one of the 1 in 4 affected, and then in future pregnancies discuss whether they would wish to do IVF and selection. But that's relates only to carriers. And then in this pregnancy chromosome testing, the NIPT gives you good information about chromosomes. The best time to do the test is when you've got a high fetal fraction, which is around 11 weeks. It can be done a little bit earlier, around 11 weeks. You typically get a result within a week. 1 to 2% of cases we don't get a result and have to be repeated or do one of the other slightly different tests. But it doesn't give you any information about anatomy. So I always tell them we need 2 anatomy scans, 1 at 13 weeks and 1 at 20 weeks with a little bit of leeway. So 12 to 13 weeks, 20 weeks, or after 20 weeks to check the basic anatomy and then detailed anatomy. By 13 weeks, if you've got normal, low-risk NIPT and a low-risk early structural scan, then your chance of a miscarriage or major pregnancy complication at that point is low. Women who are at high risk of early onset preeclampsia based on high blood pressure at booking, a strong family history, previous severe preeclampsia, can be put on aspirin. And so the gold standard is 150 milligrams of aspirin or half a standard tablet, which must be taken at night according to Asprey trial. There's some evidence that starting calcium as well will reduce the risk of preeclampsia. There are plenty of authors who recommend a dose even as low as 80 milligrams of aspirin. So I tell women 150 milligrams is probably ideal, but given that we've got Cartier that's available as 100 milligrams and it's enteric coated, it's very reasonable to put those women on Cartier. And the best time to start that is after 8 weeks. And that should be continued until 36 weeks of pregnancy. So a very simple strategy for women at increased risk of preeclampsia, especially early onset preeclampsia. So placenta previa, obviously we can't prevent it. Most of the time what we see is a low-lying placenta. So it's within, technically anything within 4 centimeters is considered low-lying, but really it's anything under 2 centimeters that's significantly low-lying, and I ignore anything more than 2 centimeters. The low-lying placenta, the vast majority will so-called move from placental migration in the 3rd trimester, but actually what's happening is that the lower segment's elongating and stretching, and as it does so, the part where the placenta is attached moves rather than the placenta actually moving. And so those women should have an ultrasound at 36 weeks. So in the absence of bleeding and an absence of a placenta that's completely covering the cervix, they don't really need another scan. They don't need a scan at 32 weeks. They just need a scan at 36 weeks. That scan should be a transvaginal ultrasound to check exactly how far the leading edge of the placenta is from the internal cervical os. And that's safe to do in pregnancy in the hands of a skilled operator. And those women are at risk of postpartum hemorrhage because the mechanism by which bleeding stops is once the baby and placenta are out, the uterus contracts, and it's the contraction of the thick upper segment of the uterus that causes constriction of the vessels, and that's how that's why women don't bleed profusely from the placental bed. They bleed a little bit, but not profusely. When the placenta or part of it's overlying the thin lower segment, the uterus doesn't have the capacity to contract and constrict blood flow in the same way. So those women are increased risk of hemorrhage postpartum. And so one of the things we need to do is maximise their blood count and iron stores during pregnancy, usually orally. But if that fails for any reason, if they don't forget to take the tablets or the tablets don't work or they get bad side effects, then it's increasingly common. I know that you're all doing, many of you are doing this in the rooms, do Ferinject infusion. Mostly it lasts 3 to 6 months. If women have a gram of Ferinject, that will usually last them beyond the pregnancy, and only if they then have further significant bleeding at birth do they need further iron infusions. So one of the risks is increased risk of gestational diabetes, and we have only one validated test in Australia. That's the full glucose tolerance test. It's a horrible test. Women need to fast overnight. They go in fasting, have 75 grams of glucola, which is disgusting. I've tried it. It's approximately equivalent to 2 cans of Coke. You have to drink it within 10 minutes. And then an hour later have another blood test, and an hour later another blood test, and obviously 3 hours they have to wait there. They can't leave in case they've done something to reduce their sugars when they leave. And other risk factors for gestational diabetes, apart from advanced age, include obviously previous diabetes, polycystic ovaries, other insulin-resistant factors, family history, ethnicity. We see a lot of women from Southeast Asia, and they're at increased risk. And so for women who have increased risk, and advanced maternal age 40 could be considered a risk factor in its own right, I offer them in their first pregnancy an early GTT at 14 weeks. As well as the routine one at 27 weeks, assuming, of course, the first one was normal. I do get a number of women who either vomit up the test or just refuse to have it for a variety of reasons. And so there are some strategies for doing some sort of monitoring on those women. None of these have been validated. So they're all things that you can offer, but I always make it clear that they don't actually replace the test, but they're possibly better than doing nothing. So they can do a fasting level, not the sugar test. They can do home blood glucose monitoring. So fasting. So obviously women who get confirmed gestational diabetes during pregnancy, their next step would be to do sugar testing. So they go and see the diabetes educator. They start fasting blood sugar, and then 1 hour after breakfast, lunch and dinner. So we make it clear to them, you need a uniform spike in your postprandial sugar. So you need to eat your meals within 10 minutes, ideally, so that spike is uniform. And then you do the test either 1 hour or 2 hours from the start of breakfast, start of lunch and start of dinner. And you could do 4 times a day blood glucose monitoring for a week as an alternative to GTT, accepting that it's not a validated test, but at least gives you some idea, a reasonably good idea of what that woman's blood sugar levels are. And then you can do that at 27 weeks when their routine GTT is due, or as an early test at 14 weeks and then the full GTT, or do it both times for women at increased risk. In some countries, they do HbA1c as a routine screening for type 2 diabetes. It's not validated in pregnancy, but if women refuse to do anything else, at least you get some idea of what short, sort of medium-term sugar's been like. It won't diagnose gestational diabetes. The one thing it will do is pick up the women who had undiagnosed pre-existing type 2 diabetes. So maybe a little bit of help, but by and large, not great for GDM screening. Hypertensive disorders, I mentioned about 10% overall for gestational hypertension, and early onset preeclampsia screening. So blood pressure at booking, serum screening markers, family history, and normally we'd expect a physiological fall in blood pressure around 20 to 22 weeks. So women who don't get that physiological fall are at significantly increased risk of hypertensive disorders in the third trimester in particular. It's important to identify women at particularly increased risk, and that includes women with twin pregnancies. So I would pretty routinely put women with twin pregnancy now on low-dose aspirin, either the Cartier 100 milligrams or the half a routine aspirin, 150 milligrams, obviously taken at night. And one of the things that we're seeing increasingly now is women having donor egg or donor sperm pregnancy. So any donor gamete is at increased risk of early onset preeclampsia. So I would routinely put those women on preeclampsia prophylaxis. So all women with twins, all women with donor egg or donor sperm IVF, I would put on low-dose aspirin, and I would start at between 8 and 12 weeks. And I would continue that till 36 weeks. So 150 milligrams at night, that was the Asprey trial. 100 milligrams, as I said before, would be perfectly acceptable, and that's quite easy because that's a Cartier tablet. There's some evidence of benefit of calcium, so calcium 2 Caltrate tablets, and just so I always tell them, don't take it with tea, coffee, dairy, or calcium. Don't take iron and calcium both. Don't take it with tea, coffee, dairy, because they all reduce absorption of both calcium and iron. So preterm birth, we know that's associated with advanced maternal age, associated with an increased risk of preterm birth. The risk is relatively small. There's no test that we can do that will identify an increased risk in that woman other than a shortened cervix at the morphology scan. So now most of the ultrasound practice will offer or do routinely a cervical length at the morphology scan. But if not, it could be asked for specifically. And that tells you if the cervical length is less than 2.5 centimeters at around 20 weeks, that woman's at increased risk of early of preterm birth. And then we've got 2 treatment options, or actually 3 treatment options. One is just surveillance, but I think if you've done a predictive test and it showed an increased risk, it should be acted upon. Then there's 2 equivalent strategies for managing increased risk. One is cervical cerclage and the other's progesterone. Head-to-head studies of the 2 things show that cerclage and progesterone are about equally effective. And given that cerclage is difficult and painful and intrusive and runs the risk of infection and rupture membranes and bladder injury, it's really a no-brainer that would offer progesterone as the first line. So I offer them progesterone starting as soon as, so there's 200 milligrams daily as a progesterone pessaries. There's Oripro or Utrogestan. They're both equally effective, but Oripro is very messy. I mean, Utrogestan is not great, but I would always recommend Utrogestan in preference to Oripro just because it's slightly less messy. Cerclage, then I would save for rescue cerclage. So women who were on progesterone and so continue to monitor the cervical length. So if a woman had increasing cervical shortening despite progesterone, then I would offer her cerclage, which we do here in the hospital under anaesthetic. And I've mentioned large and small for gestational age and women at increased risk. So in my practice, I offer women a growth scan at 36 weeks. I know that's not New South Wales Health routine, and I totally accept that the yield across the board is relatively low, but there are enough studies showing the scan between 35 and 37 weeks does help reduce some of the, or mitigate the risks of late pregnancy complications, including stillbirth, and so I think doing a scan at 35 to 37 weeks is reasonable, and women at increased risk or significantly increased risk, especially the very small baby, I would do at 32 and 36 weeks. The other things that are helpful are the amniotic fluid volume, particularly in late pregnancy, and the fetal movements, and we've got a few new projects that have recently been launched. So the My Baby Movement project, and then also the Still Aware booklet. And I'm sure all of you are familiar with this, but this is a little pamphlet that's produced by the Still Aware. So it's www.stillaware.org. And they provide these pamphlets free to clinicians, free to patients. You can order them online. It's packed on the inside with quite helpful little information, starting with, your baby's the size of a grape at 9 weeks and an apple at 15 weeks, and then a rock melon, then a watermelon, and so on. But also, you can have 200 milligrams of caffeine a day, which is 2 large coffees. So it's full of helpful information, but one of the things it focuses on is when to be concerned. And we know that women who have reduced fetal movements at term have approximately 10-fold increase of stillbirth. So it's a really, really critical issue, reduced fetal movement. So I do tell women that at around 36 weeks, they notice a change in the movements very typically, that they often notice a transition from big vigorous kicks and punches to more muted wriggles and squirms, and that's completely normal, but the frequency of movement should be maintained. And if they get worried about movement, particularly in the third trimester, then please present to the hospital. And if women have multiple presentations, then I arrange for them to have routine schedule. So after about 2 or 3 presentations, about the third presentation, then I would book them in once or twice a week for routine CTGs until birth, to prevent the onus being then on the woman to have to determine whether she needs to do that. So I would recommend this booklet for you. I think it's particularly helpful and very easy to get hold of. Yes, that's still aware. It's a free resource for women and clinicians. Now, there's no way of sugarcoating the discussion about stillbirth, and I think it has to be had with all women in every pregnancy. And I think if it's discussed prospectively, it's always very daunting to talk about and confronting for women to talk about stillbirth. But I think when it's, so I try and do it routinely and say this is a routine discussion I have with all women, because it helps for her understand what things that she can do, and also why we do most of the things we do in late pregnancies. A lot of the things we do in late pregnancy are, although we don't discuss this specifically, are around minimising stillbirth risk in late pregnancy. And one of the things that we do need to discuss is timing of birth. And so we're balancing the long-term risk of prolonging the pregnancy with the long-term benefits of prolonging the pregnancy. And we know that if you look at population data, we know that there's a massive benefit to the baby of staying inside. So short-term benefits of prolonging gestation. So babies come out, they're more alert, they breathe more easily, they're less likely to have fluid on the lungs, they're less likely to have jaundice, they feed better, but also long-term things. And these are easily demonstrable in big studies. So school performance, IQ, neurodevelopment, behavioral, all these really, really big things are demonstrably better if you prolong gestation. So there's definitely a benefit to the baby of staying inside. Now that benefit tails off after about 39 weeks. So there may be small benefits after 39 weeks, but they're very, very small from very big studies. So we can be reasonably confident in the figures. And the benefit is 0 after 41 weeks. So I do usually tell women the safest time to have your babies between 39 and 41 weeks. Now, some women aren't ready at 41 weeks, and that's fine. If it's a low-risk pregnancy and there's been good growth and baby's moving, there's no requirement to have your baby at 41 weeks, but it's at least a discussion that needs to be had, because there's no benefit to the baby. The main benefit after 41 weeks is spontaneous labour, which is incredibly important to some women. So letting the pregnancy progress beyond 41 weeks is fine in that context. And this is a big issue in this hospital, and it's one that we have raging debates over, because our hospital policy, which I personally disagree with, is that we don't offer women induction until 40 weeks and 8 days. And in fact, we don't even discuss the ARRIVE trial routinely with women. And I have absolutely no issue with women choosing to prolong pregnancy and not be induced until they're 41 or even 42 weeks. But I do actually object to not providing that information and giving women the option of being induced if there's capacity. And with the reduced number of births that we have across the state, but particularly here in the last couple of years, we've got much better capacity than we did previously. So that's an issue that I think has to be discussed with women. So I've mentioned benefits of prolonging gestation, so short-term benefits, long-term benefits. But the flip side, of course, is the risk. So we know that, so the risk, we know the stillbirth risk increases very slowly from about 38 weeks. Fortunately, the risk at 38 weeks is extremely low, and the increase in risk week by week remains very low. So these discussions are always nuanced, but I try and advise women that they've got a very slowly increasing risk from 38 weeks, with an uptick in risk at about 41 weeks and a further uptick in risk at 42 weeks, and that's across the board. With additional risk factors, so that's in a low risk pregnancy, with additional risk factor, that curve shifts to the left. So women at increased risk, whether it's advanced maternal age, hypertension, diabetes, whatever the risk, that increase in risk starts at about 40 weeks, and the bigger increase starts at about 41 weeks. So what we come back to is that women with increased risk factors, including women with advanced maternal age, the safest time for that group of women to have their babies between 39 and 40 weeks. And that, in fact, has been shown in, so there's a couple of studies to mention, I think, here. One is an old study, so almost 20 years old now, from Nicholson. It's a retrospective study, so not perfect, but it's reasonably big numbers. They found that the best time, the safest time to have the baby for women of over 35 was between 38.5 and 39.6, so essentially 39 to 40 weeks. In the past, we always avoided induction of labour prior to 41 weeks because it was always deemed that inducing women under 41 weeks increased their risk of caesarean section. And we know from the ARRIVE trial that's not the case. So ARRIVE trial, which is 6-7 years old now, and a reasonably good study with reasonably good power showed that when you induce women, you have no increase in the rate of caesarean section, in fact, a slight decrease, but it's only slight. It's sort of 19% instead of 21%. So across the board, it's about 20% no matter what you do. But a slightly lower infection rate, slightly lower neonatal nursery admission rate, and an increased maternal satisfaction rate. So most of the parameters were in favour of induction of labour. So that's not to say women should be induced, but induction should be offered, and women given the option if they want it. At the 2 minutes, okay. Okay. So caesarean section rate we know increases with age, and some of the studies have said by age 40 your risk of caesarean section is approximately 15%. And so much so that once you're reaching a 50% caesarean section rate risk, I think it's reasonable to offer women straight up Caesar at age 40. And some women want it and some women don't want it. But for the women who want it, I think it's reasonable based on late pregnancy risk and also the risks to the woman of pelvic floor injury, hemorrhage, so pelvic floor injury, uterovaginal prolapse, urinary incontinence, especially stress urinary incontinence. And some women take those risks and say, no, that's fine. I want to try vaginal birth. Absolutely fine. Other women say, no, I'll just have a Caesar. I think that's fine too. We do know that there are potential downsides of caesarean section because it may impact on feeding. It may impact on the baby on the baby's microbiome, and that's a whole area that we're still learning about. And it does increase the chance of fluid on the lungs and baby developing transient tachypnea of the newborn. But it's a relatively short-lived problem, but it does require separation because the baby need to go to the nursery. In observations from my practice, I'm seeing a wealth of women with increasing anxiety in pregnancy, health anxiety in particular, anxiety around their own performance. And I've noticed that managing pregnancy, the discussions have taken longer and longer. I don't know if that's me or them, or a combination of the two, but it's certainly an observation from my practice. And the other thing, I'm seeing a lot more women who don't have a partner who are doing IVF and going through pregnancy, intending to be single mums who haven't thought through how challenging some of the aspects of pregnancy and new mum management is, and so I tell them you need to be prepared and sort of who's your village, who's around you supporting you, and that's something that I think is helpful. And sometimes there's a disconnect between what they're expecting of themselves and what their reality is going to be. So I think it's helpful to sort of lay the groundwork for them. But it's not all bad news. So some of the studies have shown very protective effect of advanced maternal age. So obviously greater emotional maturity, they're more prepared for motherhood, and that may translate to better, behavioural issues with baby, and they've got much better health literacy. So in summary, so advanced maternal age is really a spectrum, and the risks increases risks increase at all stages and for most aspects of risk. Some of them can be mitigated with relatively simple strategies. I think stillbirth risk must be discussed, and I think that women should have a discussion about timing of birth, because that's really important. But there are some benefits that I talked about, and I would again recommend this Still Aware booklet to you. It's got a lot of references. I'm happy to take any questions.
I just had a question. Is this on? I just had a question for online audience. They wanted to know, is there a difference between first baby after 40 versus subsequent second or third pregnancy, etc., after 40?
Yes. So I think most of the risks relate to first pregnancy. And if you've had a previously uncomplicated pregnancy, almost all of the risks that I've discussed today come down. So your risk of miscarriage goes down, your risk of hypertensive disorder goes down, your risk of diabetes goes up with age, but it drops by virtue of the fact that it's not your first pregnancy more than the age-related increase, unless it was a very, very long time ago that you had the last pregnancy. So by and large, significant reduction in risk with subsequent pregnancy, or subsequent uncomplicated pregnancy, I should say. No. So we know from really, really long-standing studies, aspirin, low-dose aspirin, very safe in pregnancy. So non-steroidals, as a rule, are associated with miscarriage in the first, increased risk of miscarriage in the first trimester, increased risk of cardiac, ductus problems in the third trimester after 30 weeks. Second trimester, actually, anti-inflammatories aren't associated with a known problem. So occasionally women with severe inflammatory conditions, I put them on a short course of non-steroidals in the second trimester. But low-dose aspirin is very safe during pregnancy, and there are actually a lot of studies showing safety. No need to start it, and not advised to start it pre-pregnancy. I would start it at or after 8 weeks. 10 to 12 weeks would be fine. And continue till 36 weeks. Yeah, so for preeclampsia prophylaxis, it needs to be started prior to 16 weeks and continue to 36 weeks. Well, the blood pressure is, so pre-existing hypertension, the blood pressure is 160 at systolic, you've got a problem. So yes, well, there's no problem starting aspirin. I'd start aspirin anyway, but I would actually admit that woman to hospital until you got her blood pressure under control. I mean, so that's a problem. 160 as a booking blood pressure, because normally you get even by 8 weeks of booking, you get a physiological fall in blood pressure. So 160 at booking is a severely abnormal blood pressure.
There was another question online. They wanted you to talk, hopefully briefly, about serum marker for preeclampsia. When is it best to do this, and how do we interpret the result?
So best to do it between 11 and 13 weeks. It's a PLGF, and the best way actually to do it is to do it in conjunction with the NIPT and early structural scan. So I would refer them for so ideally you do blood pressure readings. It's tricky because the study did 4 blood pressure readings in a quiet dark room, and looked at family history of blood pressure at booking, and PLGF, and at a composite. But it's the PLGF that really differentiates the women at significantly increased risk. So do a PLGF between 11 and 13 weeks. In practice, because I use ultrasound care as my sort of preferred provider, and yes, they're far more expensive than Spectrum or Sydney X-ray or anything like that, but they provide a composite service so that they will do PLGF screening as part of their NIPT and early structural scan. Now, I know that's not within the reach of everybody financially, but that's the ideal.
We'd like to all thank you for giving us this informative talk and a small token of our appreciation. And certainly I agree, there's a lot more pregnancies, including first time over 40, which is a challenge. Thank you very much.
Okay, we're going to start the afternoon. To start the second half of the conference, I would like to introduce Dr Giselle Crawford, who will be presenting a talk on menopause update. Dr Giselle Crawford is a gynaecologist with subspecialty qualification in reproductive endocrinology and infertility. She is a conjoint lecturer at UNSW and has public appointments at Royal Hospital for Women and RPA. She consults privately at Alana Healthcare Kensington and Monash IVF, Sydney CBD. Please welcome Dr Giselle Crawford.
Thank you for having me today. So I've been asked to talk on menopause, and I think we've got some really exciting updates in terms of the current menopause service, not just here at the Royal Hospital for Women, but statewide, that I'll talk you through. I'm also going to touch a little bit on some what I think are really fantastic resources in the menopause space that you may already be aware of, but if not, they may be something that you want to have a look at. And then a bit of an update on some clinical things as well. So first of all, let's talk about the Menopause Task Force project. Now, a little bit of background to, I suppose, the importance of this project. It's a recent Australian survey, 400,000 women, severe menopause symptoms. So that's defined as, 10 hot flushes per an hour, day and night, waking every 30 minutes. 1 in 3 have severe body pain. Many have severe headaches, and the majority will also have really terrible sleep problems. And it's quite incredible, the very low number that actually receive treatment. And the commonest treatment that is being received is SSRI. By the age of 60, 80% of women will report some vaginal dryness if they are asked about this. And many are very much not aware that it can be quite easily treated with vaginal estrogens. We also know the really profound impact of the menopause transition on mood, with an 20 times increased risk of depression and anxiety during the menopause transition, and an incredible 5 to 10% of women will suffer from suicidal PMS in their 40s. 1 in 8 women will have severe hot flushes forever, so they will really suffer with this for a long time. The Australian Institute of Superannuation Trustees has estimated that this has a really huge cost for the economy, with over 35 billion a year, and a lot of this is in lost earning capacity, lost productivity, because of the impact that this has on women. So the Menopause Task Force project came about with one of the prior New South Wales governments. It was the brainchild of the Honourable Bronnie Taylor when she was the then Minister for Women's and National Senator. And essentially it was announced in late 2022, $40 million over 4 years allocated to the setup and continued funding. And at the time that it was announced, there was a lot of fanfare, it was in the media, and of course with change of government, it didn't eventuate until very late last year when some of the first payments started to come through. So there has been a bit of delay in this initial promise. So the purpose of the task force and the project is looking towards services that will work with primary care to ensure access to specialist menopause multidisciplinary clinics and care. And it's really about providing an opportunity to improve the overall health for women in their midlife and really providing better access to menopause services for priority populations. A really big part of this is about empowering and providing further support to GP specialists and primary care physicians. And one of the approaches to this is something called MenoEcho. Now, if you haven't heard of this, this may be something that you may want to link into. Essentially, it's an online mentoring network model using the evidence-based project ECHO. ECHO stands for Extensions of Community Healthcare outcomes. And this is just a little YouTube video about what Project Echo is about.
Project Echo is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centres and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under Echo, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. Echo exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project Echo, changing the world fast. Join us at echo.unm.edu. Are you part of the Echo?
So we'll skip that. So Project Echo was initially something that was designed in the US, and it was really about disseminating information and care for people suffering with hepatitis. And the Menopause Task Force project has essentially used that model to develop this Meno Echo. This QR code will take you directly to an online registration if this is something that you'd like to register for, and you'll get updates about the upcoming bi-monthly meetings, which do fall on the fourth Monday of every other month, and the next is at the end of this month on the 27th of May. Now, the sessions feature essentially expert-led presentations on menopause and discussions and case presentations. Really, any healthcare professional interested can attend. So general practitioners, endocrinologists, gynecologists, nurse, allied health are all very welcome. There are CBT certificates available for self-reporting if you would like that. And you can submit case presentations for discussion. And this this email here is the email if you have case presentations that you would like discussed. Now, in terms of the referral pathways, it's been set up through the task force as a hub and spoke model. And so the idea is that there's a number of hubs, and there are 4 designated hubs that have been identified. And each of those hubs has a number of spokes spanning out across New South Wales. So the Northern Sydney hub is based at the Royal North Shore Hospital, South East Sydney here at the Royal Hospital for Women, Southwestern at Campbelltown, and also a Hunter New England hub. There'll be spokes throughout country New South Wales. The idea of the hubs is to focus on complex and severe cases, and that's really the focus of the funding for the hubs, and not to be particularly focusing on routine menopause cases, which could be managed through the primary care physician and with further support of the hubs. So the current Royal Hospital for Women Menopause Clinic has been in existence for a very long time. It was the second public menopause clinic in Australia. And the clinics currently include well women clinics, and these will be phased out with the current funding model. Menopause after cancer, complex cases, so medically complex, in which scenario you might be a little bit more concerned about prescribing or managing or the complexity of it. Menopause and mood, and this will also encapsulate PMDD. And we've got the premature ovarian insufficiency clinic as well, as they are also quite a unique group of women. We've also got the existing bone clinic that will be part of the hub here at the Royal Hospital for Women. The wait times do vary, and at times they do really blow out, and we're working really hard on reducing those wait times. They vary for each clinic. So we've got essentially 4 years to establish this service with, as I said, the focus being on the complex and severe, and with a reduction of the routine service for what we now currently refer to as the well woman clinics. We will be mentoring Campbelltown as they set up their hub, and our spokes include Illawarra, Southern New South Wales, the Sydney LHD and Justice. Justice Health. Currently, our outpatients gynaecology department is very full. So we've got this funding, but we actually don't have a physical place to create these new clinics. And so we're currently looking towards some extra space in what's called the old COVID building on Avoca Street. Refurbishment hasn't started yet, but we're very hopeful that that will proceed. And part of this will be teleconferencing facilities as well. The hub will be focused on the POI clinic, the hormone mood clinic, menopause after cancer, and medically complex. And so when you do refer, we will be looking towards information on that referral that will allow us to appropriately triage your patients, and enough information ideally so that we can ensure that we are getting them into the right clinic that will serve their needs. So the hormone mood clinic started very recently in February, and it's the first hormonal and mood disorder clinic in New South Wales. It sees patients for a full day every second Tuesday. And we're seeing a huge demand for this clinic already. 5 to 10% of women in their 40s, as I mentioned earlier, have severe suicidal PMDD. And that really increased risk of depression and anxiety is what this will hopefully help to address. It's currently staffed by Professor John Eden, and we've also got a psychiatrist on board, Dr Anne-Marie Rees. We've also now got funding for a full-time menopause fellow, and the currently appointed fellow is an endocrinology fellow, and that's incredibly exciting because there's rare to be an entire full-time menopause fellow position anywhere. So hopefully that will help with further training into the future as well. The wait time for the hormone mood clinic at the moment is about 4 to 5 months. Menopause after cancer is a clinic that's been established for quite some time now, and we see thousands of patients who have menopause problems after cancer. And often these the menopause for these people or these women has been induced by the cancer treatments, such as leukemia, lymphoma survivors, and particularly the hormone-sensitive cancers, such as your breast cancer. The wait time currently is 4 months. The medically complex clinic includes patients with medical issues such as a background of VTE, thrombus, severe migraine, stroke. Wait times are approximately 4 months. The hub staff at the moment, we have a steering committee that consists of Donna Garland, our general manager, Associate Professor John Eden, who's been really the head of this for many years. Dr Amanda Beach is closely working with him. New appointments include Jill Neal. Some of you may have met her outside today. She's the CNC and she's got a really big job ahead of her with this. And we've got a PA appointed, Olivia Godfrey. We've now got a sessional psychiatrist appointed. We've got a current advertisement for a half-time staff specialist, for a gynaecologist, and 3 doctors working part-time. That includes myself. Given that we've got a current advertisement, they are temporary positions. And as I mentioned, the first full-time menopause fellow. We are looking to move to eReferrals, but currently we are not on eReferrals. We are still using the older referral pathways. So if you would like to refer, we would like the referral sent through either via email or fax, whichever you prefer. It will be triaged and your patient will be contacted for an appointment. Currently, they really don't knock back referrals, but there is talk of them having to send back referrals if they don't meet their criteria once we are moving to the new funding model. So do reach out if you have any questions at all. If you have any feedback or ideas for the service, Jill is very happy to receive emails and communication from you, and that's her email there. So let's move on to talk a little bit about some resources that you may find helpful in your day-to-day clinical practice. So this questionnaire can be very useful to have a patient go through, maybe when they're in the waiting room, although I appreciate that you don't always know that that's what they're coming to see you for, particularly before treatment, during treatments, and if you're changing treatment, to see the difference in symptom management that they might be expressing. And I personally find it often makes going through the various questions much quicker because you can look at it and then speak to them in a bit more detail about that. This Monash University Practitioners Toolkit for Managing the Menopause is really invaluable. This QR code will link you directly to it if you would like to download that and look at it yourself. It's about 10 pages, very easy to read, and some really fantastic flow diagrams. You probably won't be able to read this very easily, but just to give you a little bit of an idea, essentially, you've got flow diagrams for, is this the menopause? Is it pre, peri, or post-menopause? How might you manage this patient? What sort of treatment might they be appropriate for? There's a really nice table on your non-hormonal treatments. So if you think that either they don't want hormones or you think they're not appropriate for hormones, your options for the non-hormonal treatments. And then after a review of treatment, so it does recommend that you review the patient 6 to 12 weeks after initiating treatment. Have they had symptom improvement, symptom control? If not, that may be when you do want to either alter their care or refer them on in if you feel that it is a little bit out of the scope of what you're happy to and comfortable to provide. I find this resource absolutely invaluable in my day-to-day practice in menopause. This is from the Australian Menopause Society website, and this QR code again will directly link you in, and it's essentially all of the menopause hormone therapies available in Australia. And it provides a really fantastic comparison of the strengths. So if you are wanting to switch somebody from one thing to something else, you've got estrogen only, you've got sequential, combined menopause hormone therapy, and you've got continuous, all listed there. If you do sign up to the Australian Menopause Society, there are also other fantastic resources there. So there is a whole e-module learning, and that is accredited for RAC GP and ACRRM CPD points. And they also email you about updates on unavailable patches and menopause hormone therapies. And I find that really useful, particularly when your patient contacts you and says, you know, quite distressed that they can't get their Clamara patch or whatever it might be, and you can quickly look up what's available, what can I, you know, prescribe you as an alternative. So moving on to just a little bit of an update of what's new in menopause. I couldn't go past this paper, published just this week, hot off the press, by Professor John Eden, who is the head of our unit here. And it's a really fantastic narrative review on breast cancer and hormonal therapy. Because that really big question that we get all the time, I think one of the remaining huge hesitations that women have is, will I get breast cancer? And I personally feel that I spend a lot of time discussing this when seeing a woman with menopausal symptoms who maybe I feel might be a suitable candidate for hormone therapy. Again, QR code will take you directly to this article. You may remember these sorts of articles about 20 years ago after the publications of the Women Health Initiatives studies that were published in, well, the first one was in 2002 and later in 2004. And essentially we, you know, in hindsight, had very irresponsible reporting through the media on, you know, and a bit of scaremongering really with inappropriate interpretation of the study findings. Yet 20 years on, we still have the ongoing effects of some of this, I suppose, rhetoric that was happening at the time. So we know that 1 in 8 Australian women will be diagnosed with breast cancer by the age of 85. So just about everyone knows somebody who's had breast cancer. The article that Professor Eden has published this week talks about the estrogen paradox. So interestingly, in the Women's Health Initiative estrogen-only arm of the study, the breast cancer risk was actually reduced. The breast cancer death rate was reduced. Interestingly, when you look back historically at breast cancer treatments, they have included oophorectomy and irradiation of the ovaries. That makes sense if we think that estrogen is a primary mitogen for encouraging breast cancer cell growth. But prior treatment also included stilbestrol, which is a potent estrogen. So again, there's a bit of a paradox here about what is the true role of estrogen and breast cancer development. And some key takeaways from this article. He talks a lot about the stem cells and the progenitor cells of the breast cancer tumour. And essentially, they start to provide their own estrogen to the cancer itself. And it's reported that estrogen is the main mitogen for ER-positive breast cancer cells, but the main source of estrogen is the local breast fat and its parenchyma, not systemic or exogenous estrogens, and he provides a very compelling argument for this. He concludes that the evidence presented in this review would suggest that MHT does not cause breast cancer, but rather might slightly stimulate an existing tumour to appear sooner. Okay, so not to, I suppose, completely dismiss this as a concern, because it is still a concern, but it's probably not the really big nasty concern that has been worried about over the years. So to answer that question to women, will I get breast cancer? If the woman is suitable for estrogen only, and that's your patient with no uterus, so prior hysterectomy, there probably is no increased risk. The progesterone type appears to matter, with the 2008 E3N French cohort study showed that the risk was lower with progesterone and dydrogesterone rather than the synthetic progestins as part of a combined MHT regime. There's a couple of studies now, including by Yu et al., but this was also shown in one of the initial Women's Health Initiative studies, and it really didn't get much focus at all, that MHT appears to have improved breast cancer survival. So while you might see that breast cancer diagnosis approximately 1 year earlier in women who are prescribed MHT, there actually appears to be an improved survival, and we don't fully understand why that is. And of course, it's incredibly important to consider other risk factors for breast cancer. MHT poses a risk of a lower risk than drinking 2 standard drinks per day. So your patient who says, "Doc, I just have a glass of wine every night with dinner," for most people, that glass of wine is 2 standard drinks. That potentially is a greater risk to her than MHT that you might be considering prescribing. And this is out of Prof. Eden's paper. He essentially lists the various risk factors for breast cancer. Again, apologies, that's quite small. But you can see far and above, high relative risk, greater than 4, female sex, increase in age, Caucasian. Then you go down the list, moderate risk factors. So these are things that have a higher risk than MHT, being tall, being obese, young age at menarche, late age of menopause, alcohol intake. And then we get down to the lower risk factors, including recent hormonal contraceptive usage and recent or prolonged MHT. So they are on the list, but they are quite low down compared to a number of other potentially lifestyle modifiable risk factors. So moving on to talk about a new novel agent that has been very recently approved by the TGA, indicated for the treatment of moderate to severe vasomotor symptoms associated with menopause. So this is the first new agent that we've really had in a very long time. We've been waiting for this to come about because we've been hearing about it approved overseas by the FDA and so forth. So they have labelled it Veoza, is the brand name, fezolinetant. The dose is once daily, 45 milligrams oral medication. It comes in packs of 30, 60, 100, and it's approximately $60 on a private script, not PBS covered. So comparable to a lot of the current menopause hormone therapy cost points if you're prescribing something that's not on the PBS. So we know that vasomotor symptoms are a big part of the presentation for many women, affects up to 80% of women in the menopause transition, and the average duration is quite long, 7.4 years. Women who experience vasomotor symptoms have high rates of anxiety, depression, difficulty sleeping, and an overall reduced quality of life that may impact their ability to work and carry out their day-to-day activities. And despite these profound impacts, as we've spoken about earlier in this talk, there are many women who don't access care or don't access treatment. So this drug has been able to be developed because essentially the mechanism of the hot flush has been determined. They originate in the thermoregulatory centre of the hypothalamus, The area of the brain is innervated by kisspeptin, urocinin B, and dynorphin neurons, and the KNDY neurons are stimulated by the neuropeptide neurokinin B, acting on the neurokinin 3 receptors. This action is inhibited by estrogen. So as a woman goes through the menopause and has a withdrawal of estrogen, essentially there is activation of the neurokinin 3 receptor is unopposed. And this leads to hypertrophy of the KNDY neurons and alters the activity of the thermoregulatory centre, resulting in hot flushes. So how does Veoza work? Essentially, it inhibits the neurokinin B. Sorry, it's an antagonist on the neurokinin B receptor-mediated activation, and therefore is thought to reduce hot flushes. What do the phase 3 studies show us? Essentially, there were 2 phase 3 studies together that provide data on just over 1,000 women. So, of course, always caution with new drugs. They looked at 12 months of use. So we do not have data beyond 12 months. And essentially, they showed that the number of VMS episodes were halved at week 4. So 53% using the fezolinetant versus 32% on placebo. And by week 12, 2/3 of vasomotor episodes were stopped. They showed a statistically significant reduction in the severity of vasomotor symptoms, and the impact was evident by week 1 and essentially sustained through to week 52. They also saw a reduction in sleep disturbance, which they proposed was probably a secondary effect from the reduction in the VMS symptoms. These 2 QR codes will take you to those 2 phase 3 studies. A couple of things that I want to point out about fezolinetant and my concerns or hesitations. We do have some contraindications, particularly if your patient is on CYP1A2 inhibitors, and there were a number of adverse reactions that were reported. Probably the most concerning one in my mind is the elevation in LFTs of up to 3 times normal, and this was reported in up to 2 to 3% of patients. While we don't have absolute guidelines on what you do about this, I think maybe every 3-month LFT monitoring may be warranted as we learn more about this, and that's a bit of a burden for your patient. We only have 12 months of data, and my other big concern is that the group of women that we would really love to know about the effectiveness and the safety of this is in the women who have had cancer, and they did exclude anyone with a prior malignancy from the studies. So we don't have data for women who have had cancer. So I think it's another option that you can add to your toolkit for the non-hormonal options for managing vasomotor symptoms of the menopause. But of course, it's a new drug. Let's watch this space. And finally, if you really want to learn more about the menopause, the International Menopause Society Conference or Congress is here in Australia this year. It's in October in Melbourne. If you are an AMS member, you can get discounts on the registration, and it should be a really fantastic lineup of speakers that we can all learn more from. Thank you. Yeah.
Thinking now of treating women with heart disease and women with no heart disease starting on the
So we do follow the timing hypothesis of MHT. So the studies point towards probably a benefit in cardioprotection with MHT if you start the woman when she hasn't yet developed endothelial dysfunction. So we talk about the age and we talk about how many years postmenopause, but you also have to assess, do they have pre-existing cardiac risk factors? So the general guide is that if they are less than 60 or within 10 years of the menopause, it's probably protective from a cardiovascular risk factor point of view. However, if your patient already has multiple cardiac risk factors, I would advise caution. You know, if they're a smoker, they're obese, they're, you know, all the list, you know all the list. They're the patients that you probably want to have a really careful discussion with. They are the patients that maybe you want to send through to the medically complex clinic if you want more guidance on that. I personally will have a discussion with them about the risk. If I do prescribe MHT, I definitely preference topical because of that lower thrombus risk with topical. And I will also discuss with them the non-hormonals as the alternative option. Now, I think the slightly more difficult scenario is where I had a patient the other day and she was 65, has never used HRT, and she on a whole host of other medications for epilepsy and so forth, and she went through menopause at the age of 58. And so she does meet that kind of guidance of within 10 years of the menopause because it is whichever is later. But the main consideration was interactions with her various anti-epileptic medications that we had to consider.
Is it comparable or?
Sorry, what was the first? Olivia, Tibolone. I'm not sure we've got a direct comparison available. Tibolone is quite effective, and its effectiveness for vasomotor symptoms is thought to be more like menopausal hormone therapy, which is more like 80 to 90% effective reduction in vasomotor symptoms. But we don't have a study showing us a direct comparison. So I'm extrapolating that from data where it's not a true comparison. Yes.
Progesterone, is it every day or is it 14 days of the month?
Yes, good. Yeah. Yeah, great question. So sorry, just for the audience online, the question is about how to use the progesterone. Do we use cyclical for perimenopausal women, maybe who do or don't need contraception? And do we use continuous for the postmenopausal? So if we put aside the need for contraception for a moment, the general guide is that if they are perimenopausal, so still having irregular periods, or within 12 months of the last period, we use a cyclical regime for the progesterone component. Remembering if they don't have a uterus, so no periods, no progesterone. If they are postmenopausal, 12 months or more since the last period, we use continuous progesterone. However, you need to consider, does your patient need contraception? And if they are perimenopausal, or really anyone, so if you've got I know this seems a bit extreme, but if you've got a 54-year-old woman and she's just had her last period, in theory, she could conceive, she could have a random ovulation, really. So the guide is up until 55 if they've had recent periods to still consider the need for contraception. Now, how would you provide that? One option for the perimenopausal woman is the oral contraceptive pill, but the concern in that population that many people will mention is the VTE risk that does increase the older that woman gets. And I agree with that. That's a hesitation of mine as well. So you do have to carefully consider that for your patients. You could add in a Mirena IUD as your progesterone component. Now, while that's not cyclical, it's a continuous progesterone, you would then add in your estrogen on top. So you might do a topical estrogen, for example, on top of a Mirena IUD. The other thing that I'm seeing, I myself have used and some colleagues are using, is some other progesterone-only contraceptives. Now, this is off-label, but for example, Slinda, drospirenone, progesterone-only contraceptive, in theory, off-label, you could use that in combination with an estrogen, such as a topical estrogen, if you are worried about that VTE risk with a combined oral contraceptive pill. Yes. So if they can pinpoint their period, essentially I tell them to start the progesterone right after the period, but often they can't. Often they're getting a period once every 3 months. They have no idea when it's coming. And if you're prescribing a combined tablet, they just want to get started and they're just going to follow the pack. So I warn them for the first few months, you may get some irregular bleeding as essentially their cycles are getting in line with that pack. If I'm using cyclical, say, progesterone uterogestion, prometrium. Prometrium uterogestion are the same, different preparations. So if I'm using cyclical prometrium with a topical estrogen, I usually just say to them, for convenience, use it on the 1st to the 12th or the 13th of the calendar month, because I find that what people often get stuck on is remembering what days of the month am I meant to be taking this, and then they forget, and then before you know it, you haven't had progesterone for a few months. Yes. So the studies that looked at this, so there was the LIFT study and it did show an increased risk of stroke. So it is something you do need to consider. I think really any menopause hormone therapy should be reviewed. So if you've had a woman who's gone through a typical age of menopause in her early 50s, it should be an ongoing review. And at 60, that's probably a good time point to review. Is this still a need for you? If I've got a 6-year-old patient and she's been on Liviol for 10 years, I would talk to her about changing her over to a different form of MHT if she's wanting to continue on a hormonal approach. And my preference over 60 would be a topical estrogen.
There was just a few online questions relating back to the beginning topic, just with the clinics that you mentioned. One of the questions was, does the hormone clinic see younger women with PMDD also?
Yeah, so we will accept PMDD. We realise that's a really complex area. So it's not... The mood hormone clinic is not just to find menopause, but do please provide enough information on the referral so that we can ensure that they're not kind of rejected. There is a psychiatrist in that clinic, which is a really fantastic thing for these women.
Do women have to be in the Royal Hospital for Women catchment to be seen in the hub, the menopause hub?
No, so at the moment, no, but as the spokes are appropriately set up, I think there will be a little bit more restriction on the referral circumference areas, with each local health district hopefully being supported to have their own spoke, which will be another referral pathway.
Okay, great. Any more questions?
Pro, and obviously the dose of prometrium is 200 milligrams.
Yes.
After using for 6 months, she didn't had edema, but she felt that pressure fatigue, which can happen like with water retention. So can you pump the dose like taking 1 tablet of progesterone?
I think the problem is we can't be sure that if it's been used on a cyclical basis with 1 progesterone daily for half of the month, we can't be sure that it's providing enough endometrial protection. So if it's felt that it is the prometrium contributing to the edema, you could look at changing her to something else, such as the Mirena IUD. I know Professor John Eden will have, at times will change patients to vaginal prometrium, and then that can be used every 2nd to 3rd day. But again, that is off-label. So that reduces the total dose because of the slower absorption of it. But again, we don't have clear studies showing its endometrial protection. So you'd have to be a little bit cautious about that. So the short answer is no, 100 milligrams for half of the month is not enough for endometrial protection.
There was one more question online, and it was relating back to the use of Mirena in hormonal treatment with menopause, and they asked, could you use Implanon?
Yes, in theory, you probably could. I think my concern would be about whether it's enough for endometrial protection because it is lower dose. We do know that Mirena does provide very good endometrial protection. We also use it in, hyperplasia and at times in early uterine cancers. So we don't use it. I haven't seen that done. I'm not sure about the endometrial protection. And I would be a little bit worried about the quite irregular bleeding that you could get that they may be bothered by. Yeah.
Well, thank you very much, Dr. Giselle. This is a small token of our appreciation coming out here on a Saturday afternoon. We really appreciate it. Thank you.
I'll now introduce our final presentation and speakers for the afternoon. Lauren Gecuk and Brooke McGorry will discuss domestic and family violence. Lauren Gecuk is the domestic violence educator at CESPIN. She has worked locally and internationally in the domestic and family violence sector for 13 years in various capacities, including casework, primary prevention, community development, and project management. Brooke McGorry is a social worker in the Legal Aid New South Wales Women's Domestic Violence Court Advocacy Programme. She is contracted as the Domestic Violence Navigator for DFE Assist. Brooke has over 15 years of experience working in community service sector, primarily in child protection and domestic and family violence. Brooke has a breadth of experience ranging from direct casework and casework management to policy development, training and facilitation. Please welcome Lauren and Brooke.
Everyone, thanks so much for having us today. So we're going to be talking about domestic and family violence and how to respond to patients that might present with domestic and family violence in primary care. So I'll start the presentation and my colleague Brooke will join me shortly. So before we start, I do want to acknowledge that domestic and family violence is a huge issue that impacts a lot of people in Australia. It's very possible that there are people who have had some exposure to domestic and family violence. So I want everyone to really look out for themselves, practice any self-care that you need. If you do want to take a break at any point, please feel free to do so. And if you want to leave the session, I will not be offended in any way. Please do what you need to do to look after yourself. And I do have some lines on the screen if you wanted to chat to someone afterwards, and Brooke and I can stay back as well if you did want to talk. So I have, between us, I think we have about 40 minutes to talk about a very, very complex issue. So we're obviously not going to be able to do a very deep dive into this topic today. Oh, sorry. So I've just really brought out a snapshot that will help you support any patients presenting with domestic and family violence in a trauma-informed way. So we'll have a little bit of an exploration of what domestic and family violence is. We'll talk about how to create a safe environment for disclosure in your practice. We'll talk about how to respond to disclosures, questions that you might want to ask, and then Brooke will talk a little bit about safety and support and her role and what she can do to support you as practitioners. We'll also take questions after the session. So, what is domestic and family violence? Domestic and family violence is essentially one person having control over another person with whom they have a relationship. And that relationship might be an intimate partner relationship, or it might be any family member, a parent, a sibling, a child even, anyone that there may be a carer. And when we're looking at Aboriginal and Torres Strait Islander people, it could be anyone within a kinship relationship. So it's quite broad who is encompassed in this. Ultimately, though, it's about control. What it looks like might be different from case to case, but it's really about that parent control. So if we look on the screen, this is the Duluth model. It gives a little bit of a snapshot of different examples of domestic and family violence. So, for example, it might be emotional abuse. So when we're talking about emotional abuse, that might be putting someone down constantly. So they really question themselves. They have very low confidence, low self-esteem. It might be gaslighting them, making them feel like they're going crazy. And connected to that, it might be minimizing what's happened, the violence that has occurred, denying that it's happened. So that person really questions themselves. It might be physical. So it might be hitting, slapping, pushing. Sexual violence is a big one in this as well. Economic abuse. So economic abuse would be someone controlling all decision-making and all finances in a relationship. So it's very varied. It's very varied. There are lots of different examples. I could probably stand here for the next hour and just give you examples. But I think if you're going to take anything out away from this presentation, it's that it's a pattern of behaviours. It's not a one-off incident. It is a systematic pattern that occurs in a relationship that aims to create dependence, create fear, and really take away a person's sense of self, their self-esteem, their identity, essentially making it very, very difficult to leave. And just to give you an idea of just how difficult it is to leave a situation of domestic and family violence, we have a short video. I do want to warn you, there is some swearing in this video and the content is quite heavy. But yeah, I think it's a great illustration of the barriers that women in particular face when it comes to domestic and family violence. I will actually note that domestic and family violence can happen to anyone of any gender. We do tend to see women disproportionately represented when we're talking about victim survivors. We also see some populations more represented, Aboriginal and Torres Strait Islander women, people with disabilities, people, LGBTIQ identifying people. So just an acknowledgement that they can be disproportionately impacted.
How do we know that was coming up?
Why didn't you just leave?
Yeah, that's a good one. Yeah, and people get asked this all the time.
It makes it look as if she had a choice to leave, and it puts the blame on her. It's like, why didn't you leave? They don't say, why did he do this?
None of it makes any sense if I didn't love him.
I was still in love with him because I was still trying to get back to that good spot again.
I was gonna fix him and make him a better person.
That if I just loved him enough, you know, it would fix everything.
I hated him. I did, honestly. Oh, I hated him. I just didn't have the financial means to leave.
I wasn't working. I was working for him but not being paid. I had a daughter. And it's not like someone who's just been abused can go out and work. Like, abuse fucks you up. So I really didn't believe that I would be able to stand on my own 2 feet and raise my daughter on my own.
And I guess, you know, the question said, why didn't you just leave? Well, I did. I just woke up one morning and said, I want you to go.
I did it a few times, and then it's so desperate. You feel so sorry for them.
He would grovel back to me.
Cried, he pleaded, he begged, he got angry, he yelled, he screamed, left suicide notes, and, you know, that's also a really common abusive behaviour.
All your friends go, oh, she'll be back, or you'll be back.
People around me said, well, you know, he really loves you, you have to take him back. And when I said no, it was like, well, you need a psychologist. You know, there's something wrong with you. Look, this man's ready to kill himself because he loves you that much.
He actually put me in hospital once. So I rang Mum, said, can I come and stay with you for a week or two? And she's gone, no, you made your bed, you lie in it.
I feel like I need to give everyone a minute just to sit with that, because I've watched that. How many times a week do we watch that? 1, 2, 3 times a week, Brooke and I watch that video, and it still has an impact on me. I think, as I said, it's a great illustration of how challenging it can be to just leave a relationship. What it doesn't really show, though, is how dangerous it can be to leave a relationship. So what we know from the death review report, the most recent one done in New South Wales, the majority of homicides that occur will occur 3 months after separation, where there's domestic and family violence. So it's not necessarily as simple as leaving an abusive relationship to be safe. The other thing that's sort of missing from that video is the shame. So it can be really, really hard for people to talk to someone about what's going on because of shame. But some people do disclose. And I'm interested to hear from you who you think people feel comfortable to talk to. So I don't know, just call out things to me. Who do people disclose to? Nurses? Practice nurses? GPs? Anyone else? Anyone online? Has anyone put anything in the chat? So, neighbour.
Family member?
Yep. Well, you're all right. So look, this is from a study in 2018. Friends and family do tend to get the most disclosures, but general practitioners get the most disclosures when we're talking about professionals. So they're getting more current disclosures than social workers, than police. So not to put pressure on you all, but you do have an enormous role to play in this space. And again, not to freak you out, but we do know from a study done a few years ago by the University of Melbourne that a full-time GP in Australia is estimated to unknowingly see 5 women a week experiencing domestic and family violence. So, which is why I'm here today to talk to you as GPs. And if we're talking about antenatal shared care, and if I understand correctly, you are all antenatal shared care GPs. I hope you're aware of this, but during your 28-week appointment, there is a guidance around doing domestic and family violence screening. Does everyone do that? Do you want to raise your hand if you do your screening for DFE at 28 weeks? Does anyone do it earlier? Yeah? Yeah. It's really important to be doing that screening, and the midwife as well. When the patient does go to see the midwife during their antenatal period, they will also be screened. But it's always good to have that discussion as early as possible and to touch base throughout your time with your patient. And the reason why we do recommend screening with pregnant women is that we consider them a priority population. So we wouldn't recommend screening with the general population. We would recommend mostly a case finding kind of way to engage with your patient. But with pregnant women in particular, screening is recommended. And I know some people feel very uncomfortable doing that because they don't want to make their patient feel uncomfortable, but we do know from a lot of studies that women feel okay with being asked overwhelmingly. So just a bit of information about what DFE looks like in pregnancy. We know that it often starts or escalates during pregnancy. The frequency and severity of DFE during pregnancy is twice as high as when women are not pregnant. So we do consider it a particularly dangerous time, particularly if there's been DFE prior to the pregnancy. We also see quite significant impacts of DFE in pregnancy. There are a few up there: low birth weight, miscarriage, anxiety and depression. Obviously, a disclaimer, these can exist in women that are not experiencing DFE too. It'll really be your questioning of your patient to determine what might be the cause of those things and whether DFE has a role to play. So if we want to be providing trauma-informed care to women who are experiencing DFE, there are a few things we can do in our practice to make that happen. So we want to ensure that disclosures are occurring in a private environment where you have sufficient time. Now, if I know anything about GPs, you all have so much time on your hands that you definitely can spend a very long time with your patients. I'm obviously being facetious. I know that it's very hard. You're seeing a lot of patients and you don't have a lot of time with your patients. And I was very thrilled to hear about the Level E Medicare item numbers, which do allow you to have more time, and domestic and family violence is listed as one of the issues that you can use that for. It's really important that conversations about domestic and family violence are not happening with other people in the room, particularly the person that might be the abuser. And that can be really hard because we often find that abusers like to sit in on every appointment as part of their controlling behaviour. So I would really strongly recommend that you talk to your practice and your colleagues about how safe ways that you can ask people to leave. And it might be that you say, oh, do you know what? You're due for a pap smear, or we have to do this examination and we don't allow anyone else to be in the room. And you might use that opportunity to have a discussion. And utilising other staff, practice nurses, reception staff to watch children as well. The college really is quite strong about this. They don't recommend that GPs see both the abuser and a victim survivor. This can be very challenging, and I do get a lot of backlash from GPs about this, because sometimes a GP may have worked with a family for 20 years. So how do you get rid of one of your patients in a safe way and without alerting to them that there's been a disclosure of abuse? So Brooke will talk to you about her role shortly, but she can help you have these conversations with your patients. We strongly recommend not using family or friends as interpreters. If an abuser happens to be an interpreter, that could be another tool to further control a situation and to collude with you against the patient. So really important to use professional interpreters. And we would also recommend to have DFE resources in your practice. So Brooke has an amazing amount of resources, posters, pamphlets that she can share with you, and she can do practice visits to give you all of that. And we do know so this training is actually part of a pilot, a national pilot, and we do know from other sites that are doing this that a poster in the room has led to disclosures. So that's been a real catalyst for someone to decide to talk to their GP. So once you've created that safe environment, the next thing is looking out for indicators. So there are quite a few. And again, just as I said with the impacts you might see in pregnancy, these are things that could be caused by other things. So it's going to be how you talk to your patient about it to determine whether DFE is involved. It might be that they appear nervous. Maybe they're non-compliant with treatment. Maybe they're not compliant with any tests that you want to do. Maybe they don't want to have a pap smear. Maybe there might be trauma related to that. Maybe sexual violence that might make them feel uncomfortable to have a pap smear. Maybe they've come with an injury, but their explanation of that injury doesn't sit right with you, doesn't make sense. And there are a few other behavioural ones there. It might be physical. I've got injuries to the head or neck there. When I'm talking about the neck, and I want to just draw your attention to non-fatal strangulation just for a moment. So non-fatal strangulation, we are seeing that increasingly being presented in primary care. And there are lots of indicators, and I'm going to send to my colleagues to send an email to you, some documentation around it. It's a bit too medical for me. I work in the domestic violence space. I'm not a doctor, so I don't want to talk to you about the specifics of that, but I will send you information. The reason why I wanted to highlight it is that we know from studies that have been done around this, if a woman has experienced non-fatal strangulation, she's 7 times more likely to be murdered by the partner that did that strangulation. So we consider that very, very serious. And Brooke and I did training on non-fatal strangulation yesterday. And a new stat that I learned was that 49% of people who have experienced non-fatal strangulation will present with 0 visible symptoms. So there are a lot of things like losing control of their bowels, memory loss that you might not see and the patient might not talk to you about. So just want you to have that in your mind if anyone's presenting with these some of these symptoms. Maybe they've got chronic pain that they're coming to you about. The psychological symptoms that might present, maybe they're coming to you for a mental health care plan for anxiety. Maybe they have some substance abuse issues. We do see a lot of these symptoms in people who've experienced trauma. So we would be really encouraging you to be having a conversation if someone's coming to you for a mental health care plan. All right, so we've created a safe environment. We know the indicators to look out for. Now we want to provide some good support to the patient. So this is a lives model. This is from the World Health Organization, and I think it's a really great framework for how this work should be done in a trauma-informed way. So listen, I think, is a very obvious one. We want to be listening to the patient, but it's not as simple as that. It's about letting them take the lead of the conversation. I spoke earlier about the shame in having experienced DFE. You don't want to be forcing a conversation about this. You really need to be taking the patient's lead. And if you are seeing that they're feeling uncomfortable with your questioning, you might want to step back and maybe ask again at another appointment. But ultimately, the listening is also about not being judgmental and being empathetic. You don't have to be detectives to determine whether what you're being told is correct or not. We know overwhelmingly that it is so rare for a false allegation. So really, you should just be believing your patient. It does no harm to support a patient who's coming to you. So we're listening and then we're inquiring. So what's recommended when you're wanting to have these conversations is a funneling system. You want to start with more general open-ended questions and then get more specific. So it might be a pretty innocuous question like, how are things going at home? How are things in your relationship? And then taking it from there. But it is important to be using specific questions once you've established that there might be something going on. The reason for that is if you just asked a patient, are you experiencing domestic and family violence? What do you think the answer would be? No. Right. A lot of the types of domestic and family violence that we spoke about earlier, a lot of people would not connect that to domestic and family violence. They would consider that a normal thing in a relationship. So we would discourage you from asking that question. Be more specific. Has your partner or family member, whoever it is, ever hit you, ever pushed you, ever applied pressure to your neck? So even the term strangulation is not a term that we would encourage you to use. Has your partner ever done anything that made you feel like you couldn't breathe? Does your partner control your finances? That it's really important that to really understand what's going on, you're using the correct terminology so that the patient really understands what you're talking about. And then it's really important to find out what they want and what they need. Now, when you're in a situation where you've lost all your sense of identity, all your confidence, you feel immense shame, you might not have an answer to any of those questions. You might not know. A patient might be coming to you and asking you what they should do. But what's really important when we're providing trauma-informed care is to empower the patient and make sure that they're making decisions for themselves. Choice is such a huge, important part of this, and letting them know what options are available, what support is available, and then allowing them to make the decisions is really important. Validation. I would argue that validation is probably the most important thing that you can do with a patient that's disclosing domestic and family violence. We know from numerous studies, and I know this anecdotally from my practice as a caseworker, if a person has a really negative first disclosure, so they feel judged, they feel ashamed, they're being interrogated, they're very unlikely to ever get support in future or tell anyone else about it. However, if they have a really good first disclosure, they feel comfortable, they're not forced to answer all these questions and make all these decisions, they don't feel judged, they're significantly more likely to seek help in future. So really simple sentences like what you see on the screen can make a huge difference and be a huge catalyst. Thank you so much for sharing that with me. I'm really sorry that's happened to you. It's not okay. It's not okay. What you're describing to me is abuse, and you don't deserve that. And I'll pass on to my colleague Brooke now, who will talk to you about safety and support.
Hi everyone. So as Lauren mentioned, my name's Brooke. I work for Legal Aid New South Wales in our Women's Domestic Violence Court Advocacy Program. So we fund 27 women's women's domestic violence court advocacy services across New South Wales. So every postcode in New South Wales is covered by a service that supports women or people who identify as women who are experiencing domestic and family violence. So my role in this program is as the DFE navigator. So I'm purely available to health professionals to consult with and to support you in responding to patients experiencing DFE. So as Lauren mentioned before, I have lots of resources available that I can bring out to your practice, explaining the program that I work for, posters that prompt people to think about aspects of their relationship and what might be family and domestic violence. I can do secondary consultations. So if you're seeing a patient and you've noticed some things that you're a little bit concerned about, or if you're not sure how to ask a question or start a conversation about family and domestic violence, I can walk through that with you. So some GPs have called me and said, look, I'm having a patient come in next week. These are some things I noticed at their last appointment. How might I ask them about family and domestic violence? I've had other GPs who've actually called me with the patient in the room and they've made a disclosure and they're wanting to know what support can look like. So I'm here for all of you between Monday and Friday, 9 to 5, for you to call me and consult about any questions that you might have. There's also a lot of crossover in the domestic and family violence space between things like disability and elder abuse. So I definitely just say to people, if you think there might be some kind of power and control happening for your patient, please just call me. And if I'm not the right service, I have lots of connections in community and I can talk you through another service that might be more appropriate. As Lauren mentioned before, we know that GPs are really busy. So probably one of the most valuable things GPs have found about my role is that I can take referrals directly. So within Central Eastern Sydney Primary Health Network, there are 5 WDV CAS services. So rather than you needing, or your patient, trying to Google and find out whereabouts you need to refer your patient, you can come straight to me. I will just take a moment to explain what the WDV CAS service does, because I feel like the name is a little bit misleading. So the WDV CAS started off as a court support service many moons ago, and it has now evolved into something that's much more. So those services can provide holistic support to women and people who identify as female experiencing violence. So primarily they act as a case coordination service. So they will do an assessment with your patient around what some of the impacts of DFE might be. So that could be things like maybe some financial difficulties, wanting some domestic and family violence counselling, having issues with housing if they want to leave. So they will do an assessment to find out what all of their needs are, and that WDV CAS service will make the connection for your patients with specialised local services in their area. So that takes the pressure off you and your patient trying to find multiple services to do specific things, and they will coordinate that for your patient. The second stream that they can accept patients under is under case management. So they can actually walk alongside your patient and support them for 6 to 12 months. And that might be in complex circumstances where maybe there's, like I mentioned before, and Lauren mentioned as well, some of those priority populations like disabilities, and it may be more complex to get support or to leave if that's what the patient is wanting. We have tried to make this referral process as simple as possible. You can call me on the number on the screen. I'm option 2, Lauren's option 1, and that will take you straight to me. Or you can email the email address that's on the screen as well, and that is our team's inbox. So that is monitored during work hours during the week, and they will get it to me, or somebody will respond to you if I'm not available. I'm going to just show you the next slide. I won't speak too much about it, and we don't have time to go through this whole plan today, but this is a domestic family and sexual violence action plan. So this form has 2 purposes. It can be uploaded straight into your practice software, and so it will pre-populate with some information, but it's based on the DVSAT, which is a risk assessment tool, and what it does is it helps to guide your conversation and assess the risk for your patient. It can also act as a referral form for me. So if you are feeling a little bit confronted by this conversation, or you're feeling a little bit stuck, this can be a really good tool to help you to assess the risk for your patient and make a decision around what you need to do today. You know, do you need to call me before your patient leaves because they've said that they're concerned to go home? Does your patient feel safe to go home, but maybe a referral is a good option? This is a form, or I guess a guide, that can really help you with that. Doing this action plan does not doing this action plan, does not preclude you from making a referral. We know that you're really time poor, so if you've had a conversation with your patient and they've consented, I'm more than happy to take a referral just with their name, their contact details, so a phone number. The WDV CAS services are mandated to make contact with your patient within 2 business days, and they will make 3 attempts within 5 business days. Just a little bit of a practical tip when you're asking your patient for their best contact number, asking them when it's safe to call and whether it's safe to leave a voice message or a text message is really important. I've had patients tell their GP that, you know, I really want this support service, but they need to contact me before 4 because my husband gets home then. Or you can call me, but please don't leave a voicemail because my husband checks my voicemails. So that's a really big tip I would ask you. And also to let them know that they will receive a phone call from a mobile number. And again, that's so the WDV CASs can text because sometimes that's the preference for patients, but it can be difficult with all the scam calls that people get these days. Sometimes if they don't know a number, they just won't answer. The third thing that I would need would just be an address, so I can make sure that your referral is given to the local service that covers your patient's area, and then any information you have about what your patient is experiencing. I've had GPs who've called me and given me a wealth of information because that patient's been really open, but then like Lauren mentioned before, sometimes people might just give you a little bit and that's okay. I've had just one sentence from a GP saying that their patient's experiencing emotional abuse and that there's no physical violence, but they want to know their options to leave. And that's enough information for us to act on a referral. So just some tips in having those conversations to support your patient, asking what they would like. So I think sometimes the measure of success for people is that they want their patient to leave, and we would say don't expect that that's going to happen after your appointment or maybe ever. We know on average it takes women 7 times to leave. A really good outcome is that your patient has felt good having felt good disclosing to you and that they are happy to come back for another appointment. Make sure that you have their consent to make a referral. Our service is voluntary. Making the referral together can be a really good option. And yeah, just taking their lead and respecting their choices. Lauren mentioned before, if you're feeling like they're a little closed off when you're asking questions, it's perfectly okay to say, look, I can see you're a little bit uncomfortable. Just know if you want to talk more about this, I'm available next time. Why aren't you moving? There we go. So this is our pilot, so DFB Assist. So we've given you a little bit of a taste of our training today. We are definitely open to coming to practices if you feel like other GPs would benefit from some training or doing some more specific training to the demographic that you see. And as I mentioned before, I'm available ongoing for consultations and support. More than happy to come out and do a visit to drop some resources off and work from the practice for the day just to talk to other GPs or be available for any consults, or you're also welcome to contact me via that email or the number on the screen. Do we have some time for questions? Do you want to join me?
Sure, I'll join you. I just want to also mention that if you're looking for some CPD hours for reviewing performance, if you have Brooke come over and you bring some case studies that you want to talk through, you might be able to get those hours. So just a bit of advice. Hot tip. Hot tip. Any questions?
I have a question. If we tell them to call 1-800-RESPECT, can that funnel to you guys? Like, where does your caseloads come from as well?
So 1-800-RESPECT can be a great resource. It is a national number though. So it may funnel through to the WDV CAS. That's a pathway that they do refer to, but it can be less direct than if you have a patient in front of you wanting that support coming to me. You can also call 1-800-WDV CAS, and that's the New South Wales number. So it will ask you to put in your patient's postcode or your patient to put in their postcode, and that will take them to the local service that covers that area. So that's also an option as well.
Any more questions?
Yes.
Bring more email with.
So ideally it is for health professionals. I guess part of this pilot, given the amount of disclosures we talked about before that health professionals are getting, we really want to support health practitioners to upskill and gain their confidence in having those conversations. But I'm always open to supporting you with a conversation. So if you want me to be there or be on the phone, or if you want me to call your patient, I guess I would just ask that come through you. So the health practitioner give me a call and say, hey, maybe it's quite a complex matter or you're not confident in having that conversation. I'm more than happy to give your patient a call.
Can help you in acute situations. You know how they're going to receive $5,000 for immediate help. I think that will actually practically work.
It's becoming a political.
No.
Do you want to talk to that?
I can talk. Look, it is, leaving can be very difficult. I think there is also a lot of work to do in the primary prevention space. I think that we probably need a bit of a multi-pronged approach, because what we want to do is we want to support healthier relationships prior to getting to the point of domestic and family violence and people needing to leave. So I definitely would say our frontline services are understaffed and underfunded. There's also a huge issue in the DFB sector of work being contractual and funding being contractual. So it's almost like you're halfway through your funding period and then a lot of energy and resources is putting into a new funding bid as opposed to providing the service. So I think it helps, but it's not the only part of the puzzle. I hope that was neutral enough.
Well, thank you very much for spending a Saturday afternoon here, and also for doing the work you do. It's very important, and for helping us support also families in the community. So thank you very much, Brooke and Lauren.
Thank you. Thanks so much. Thank you. And so I just want to say your health pathways do have domestic and family violence pathways that have really good information.
And thank you to all our speakers and for all of you attending, especially on Saturday afternoon.